யாரு யாருன்னா யார் சொன்னாங்க?
நீங்க தான் நல்லா மீட்டிங்ல டாக்டர்ஸ் டே செலிப்ரேஷன்ல நிறைய பேசி நல்ல வசனமா எல்லாத்தையும் இது பண்ணி பேசுறீங்கன்னு சொல்றேன்.
அது சரி, ஏன் மொத்த மீட்டிங் காட்டல? இந்த ஒரு 3 பேர் பேசினது மட்டும் போட்டுருக்காங்க.
தெரியலையே.
எதுங்க சார்?
நான் இன்னும் பார்க்கவே இல்லை.
கார்த்தி, ஏன் வந்து ஆரம்பத்துல இருந்து இல்ல?
ஸ்ரீதர் சார், டு பி வெரி ஹானஸ்ட், வந்து நம்ம வந்து வீடியோ ரெக்கார்டிங்கே சொல்லல. ஒன் ஆஃப் தி அவார்டீஸ் சொல்லி புதிய தலைமுறை வந்து வீடியோ எடுத்துட்டாங்க. எடுத்துட்டு பணம் கேட்டாங்க. நான் கூப்பிடவே இல்லையாப்பா அப்படின்னா, இல்ல சார் எல்லாம் ரெக்கார்ட் பண்ணிருக்கோம்னா, சரி ரெக்கார்டிங் அனுப்புங்க கொடுக்குறேன்னு சொன்னேன். அதனால அவங்க கிளிப்பிங் அமைச்சதுக்கு மட்டும் 1500 rupees கொடுத்தாங்க. டெக்னிக்கலி இட் வாஸ் ரெக்கார்டட் பை த பிரஸ், நாட் பை அஸ். நம்மளது போட்டோ மட்டும்தான்.
ஓ,
அதனால வாட் தே ஹேவ் ரெக்கார்டட் we have got.
இருக்கு.
You know, as usual, press வந்து they were asking for இது. நான் சொன்னேன், நீங்க ரெக்கார்டிங் கிளிப்பிங் அனுப்புங்கப்பா, அதுக்கப்புறம் தரேன்னு சொன்னோம். So after they gave some clippings, we paid. Officially we asked only for we asked only for photographers, sir. We didn't call video recording at all. The video recording was done by press people. And the press was called by one or two of the participants.
1 கிலோ தான் நினைக்கிறேன். பார்த்து எதுக்கு 200 ரூபாயா கொடுக்குறேன், கையில வச்சுக்கிறேன். நீ போனுமா
வாங்குற அவார்டா புதிய தலைமுறையில காட்டுங்கிறதுக்காக பிரஸ்ஸ கூப்பிட்டுருக்காங்க பாரு.
யாரு
மீட்டிங்ல எப்பவுமே உட்காந்து பேசிட்டு இருக்காங்க வீட்டுல.
சரி,
ஆரம்பிக்கல. ஆக்சுவலா முன்னக்கூட்டியே லாகின் ஆயிட்டேன், இல்லைன்னா இடம் கிடைக்காது லாகின் ஆறது.
நான் மீட்டிங் முடிகிற வரைக்கும், நான் பேசுற வரைக்கும் இங்கதான் இருந்தாகணும்.
Hello.
Sir.
We'll start பண்ணிரோமா?
Yes sir. Sir, Sengatun sir, shall we start, sir?
And it is,
yes sir. Yes sir.
Sir, எல்லாரும் வந்துட்டாங்க.
Yes sir. We will start, sir.
Yes sir. Okay.
Sir, President sir, shall we start, sir?
Yes,
President sir,
you can start.
Shall we start the meeting, sir?
Start பண்ணிக்கலாம்.
Okay sir.
Yes sir. Okay sir. At the outset, I would like to welcome all of you for this annual state CGP conference for the year 2025, being held in a hybrid mode from today, 8th July to 12th July, which is 12th July being to attend in person at IMA Pollachi Hall. First, I would like to start with the IMA prayer. IMA prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every creed and lure. Physician's prayer. Dear Lord, thou great physician, I kneel before thee. Since every good and perfect gift must come from thee, I pray, give skill to my hands, clear vision to my mind, kindness and sympathy to my heart, give singleness of purpose, strength to lift at least a part of the burden of my sin, and a true realization of the rare privilege that is mine. Take from my heart all guile and worldliness, that with the simple faith of a child I rely on thee. Thank you. Now I request Dr. Sendil Kumar, our Director of Studies, IMA CGP, to give the welcome address. Dr. Sendil.
Yes, sir. Thank you, sir. So at this outset, I thank our State President, Dr. P. Senguttuvan, sir, our State Secretary, Dr. Karthik Prabhu, sir, our President-elect, Dr. Sridhar, sir, past President, Dr. Abul, sir, our Treasurer, Dr. Gauri Shankar, sir, for giving this wonderful opportunity to organize the annual state conference in online mode and also with the hybrid mode on the last day. I thank all our participants who are registered in large numbers, and I welcome all our members who have been in this conference right now. I request you all to continue throughout the session and make this session useful for your day-to-day practice. And I welcome all our faculties and our coordinator for the day, Dr. Neminathan sir, Dr. Raghunandan sir, Dr. Suresh sir, Dr. Mohan sir. All are well-known faculties in our CGP forum. I welcome you all, sir. Over to you, sir. Thank you.
Thank you, Sendil, for the short and brief welcome address. Now, I would like to welcome our President, sir, Dr. P. Senguttuvan, sir, to give his words of felicitation and his presidential address. Senguttuvan, sir.
Thank you, Anand, for your
and also to inaugurate our conference today, sir.
Right.
Yes, sir. To declare open.
Thank you, everybody. Respected President-elect Dr. Sridhar, Honorary Secretary Dr. Karthik Prabhu, President, immediate past President Dr. Abul Wasan, Finance Secretary Dr. Gauri Shankar, Hospital CGP Director Dr. Sendil Kumar, Secretary Dr. Anand Chokkalingam, and faculties Dr. Neminathan, Dr. Raghunandan, Dr. Suresh Kumar, Dr. Mohan, and the participants. I am very glad that during my tenure, we have started this conference for the second year. Now, during the director of Sendil period, this is the third conference, I think so. So every year we are promoting this the college in CGP programs in a nice manner. I think now it has been crossed to 2000 and odd. Really, I'm very happy to note that CGP is doing a wonderful job for doing these academic activities, and it will be very useful to all the practitioners to enlighten their knowledge. So with these words, I inaugurate the CGP conference for this online mode, and offline mode, the hybrid mode will be on 12th at Pollachi. I request the maximum participants to come over to Pollachi and enjoy the hospitality of the Pollachi IMA branch and Director of the CGP Studies, Dr. Sendil Kumar and Anand Chokkalingam. With these few words, I over to Dr. Anand Chokkalingam. Thank you.
Thank you, sir.
Thank you, sir. Very kind of you to give us such a felicitation, sir. I would like to keep your hope alive, sir. Thank you, sir. Now I request our State Secretary, Dr. Karthik Prabhu, sir, to give his words of felicitation and State Secretary address. Karthik Prabhu, sir.
Yes, sir. Thank you, Anand, sir. Most respected President, Senguttuvan, sir, Sridhar, sir, President-elect, Sendil, sir, CGP Director, and Anand, sir, Secretary, and all the speakers, Neminathan, sir, and everybody today. Good evening, everybody. Sir, I'm really very happy and proud to see that good numbers have been attending, and close to now 786 are already there inside. And CGP, though we know that it is not a degree that people can claim themselves as a consultant, but the kind of empowerment it gives to the general practitioners and the confidence with which they can practice scientific medicine has been very detailedly worked out, structured, and beautifully done by Team CGP, and all its courses are doing extremely very well. And especially this year and the last year, Sendil sir and Anand sir are doing a phenomenal job, and the quality and content of the preparations are fantastic, sir. Really great, and hats off to you. And I'm sure today I just went through all the days of programs, sir. Each and every day you have carefully sorted out and handpicked the people who are pioneers in that particular specialty. For example, today, name and answer doesn't require introduction. Any of the infectious disease, is so beautifully doing it for the last so many years. And many have looked forward for looking into that. And Raghunandan sir and Suresh Kumar sir, all well-known people, sir. Very, very well done. And best wishes, sir. I wish all success to the program and also in coming years. Thank you. Thank you, Anand sir, for the opportunity.
Thank you, Dr. Karthik Prabhu, sir, for your kind words, and we will try
Thank you, sir.
to maintain this in the future coming conferences also. Hope to keep your hope live. Thank you, Karthik, sir. And now myself, I'll give a short and sweet address before going into the felicitation by Sridhar, sir. See, as all you know, as Karthik Prabhu sir told, we conduct 7 courses, and those courses, as he told, it's not a qualified degree which can be sufficient in your board. We write it in the thing itself, but it gives a very good empowerment for the general practitioners to do a scientific practice, whereby, suppose, even though you are a people are general practicing, if you are held up in a court of law, you will be able to answer those things correctly by giving a correct treatment method. So that will be helping you to empower yourselves. So I want to, as Karthik Prabhu sir told, I want to specifically make a stamp of it here in this conference, since 2,500 people are already registered and attending this. So to make a note of it. And then there is a fellowship course in diabetic medicine, diabetic foot, clinical infectious disease. And then you have a course in respiratory medicine. You have a course in reproductive medicine. You have a course in sexual medicine. And this year, in this conference, on the 4th day, our CM is on neurology. And in that, we are inaugurating a new course, not until done this time. This is going to be neurological course, which will be helping the general practitioners in their day-to-day practice. So it is again, as Dr. Karthik Prabhu sir told, it has got a very good faculty of neurologists and ENT surgeon from the state of Tamil Nadu. So people who are interested can just contact me or Sendil. We'll be always helpful and guiding you to join the course. Coming to this course, today's first day is regarding infectious disease. Second day is for diabetes and hypertension. Third day is for snoring. So, like, what is snoring has to done with general practice? So, as a general practitioner and the family physician, the patients first approach a general practitioner like, I have a snoring, like how to proceed with. So now there are lots of people practicing sleep medicine. So the patient gets confused whom to approach and what to do. So that we have planned that new thing in this conference. And the 4th day is going to be regarding neurology, as I told, and 5th day will be regarding plastic surgery for general practitioners. It will be an in-person conference. People who are willing to attend can please attend there at Pollachi at evening 5 o'clock in Pollachi IMA Hall. So with these few words, I would like to thank you for participating in great numbers and supporting all our CGP in the Tamil Nadu State CGP in our endeavors which we undertake. Thank you very much once again. Now I request our President-elect Dr. Sridhar sir to give his words of felicitation and his presidential and his address. Sir.
Thank you,
Sridhar sir.
Anand. Can you hear me?
Thank you, sir. Thank you very much. Yes, sir.
Yeah.
Yes, sir.
Most respected President Secretary Karthik, immediate past President Abulbhai, the Director of Studies Dr. Sendil Kumar, and yourself Anand, the great speakers are waiting to give updated knowledge on infectious diseases today to more than 2,000 delegates, I suppose. Already 1,000 have joined, 944.
Yes, sir. 2,500 have registered, sir. Yes.
No to join. 2,500 have registered and nearly 927 have joined. That is very great numbers. Here, I would like to enlighten our delegates, not the office bearers. They know all the details. See, Indian Medical Association once started for fighting the freedom struggle in 1928, now has become a multifaceted organization. Remember the Hindu goddess Adi Parasakti with multiple hands. One will hold a sword, the other will hold a shield, the other will hold a spear, the other hand will hold an axe, and one of the hands will hold the books, textbooks. So, Indian Medical Association now has become an Adi Parasakti, the goddess supreme, with multifaceted outreach to its members. On one side, it is protecting them from litigations. On the other side, it is offering solace to the bereaved members of a departed soul, and they help you fight your litigation cases through PPLSS and day-to-day administration of the hospitals, updating the knowledge on healthcare system. On the other side, fighting for your rights like minimum wages, insurance, other things. And one of the hands, or let me say two hands, hold two departments, the AMS and the CGP. And both are competing with each other to outshine each other. And this competition is very healthy and very entertaining to watch. And we had this AMS conference culmination only last week, and now this is CGP. And very delighted to see. Generally, the impression among members is IMA is for the oldies. Only the retired people or the aged people will be part of the Indian Medical Association. Now we see young faces, people with excellent academic knowledge, research attitude, joining IMA and refreshing the various academic departments with their knowledges. Look at they are also they are educating in institutions like Anand Chokalingam, Sendil Kumar with his academic knowledge, Neminathan coming forward with his infectious diseases, Suresh Kumar giving us a wide depth of knowledge from Apollo Chennai. See the variety now our members are capable of getting from Indian Medical Association on the knowledge side has widened and brightened. So I think we are going to grow only from strength to strength from the days when I was the PCGP secretary to date, when science and artificial intelligence have taken over every organization. I am sure CGP will reach much higher heights in the future and will be helping our members, especially in the periphery, keep themselves updated. Excellent work you have started. This is the first day. I wish you all the best and great success for the rest of the days with a beautiful ending, a culmination of a hybrid meeting in Pollachi. And I wish you all best. Thank you, and over to Anand.
Thank you, sir.
Thank you, sir.
You have just highlighted what IMA is to this large number of gathering here, sir. So that is because I see lots of members who are non-IMA members who are attending this meeting. So it's a double-edged sword, like you mean. It will help them to know what IMA is and what you can do by joining IMA in your not only in your practice, in the rest of your life also, sir. So thank you for your kind words of appreciation, sir. We'd like to try to keep up, sir. Thank you very much, sir. Thank you, sir. Now I request Dr. Neminathan, sir, to take over the proceedings and conduct today's, since there are 1,000, now it is 999 and is 1K now. So Neminathan, sir, people are waiting to watch the quality of content from the infectious team, sir.
Yeah. Is my slides visible, sir?
Yes, sir. Your slides are visible, sir. Please, sir,
Yes,
you can.
Yes, sir. Greetings from Infectious Disease Certificate Course core team. Myself, Dr. Neminathan, and Dr. Goindeswamy sir, past Director of Public Health, Dr. Raghunandan sir, Professor of Medicine, Coimbatore Madras Medical College, Dr. Suresh Kumar, ID Specialist from Apollo Chennai, Dr. Mohan Kumar, CDC Epidemiologist from Chennai, and Dr. Suri Kumar, HOD of Microbiology. We six of us combined together, we conduct this IMA CGP TNSC Infectious Disease Certificate course. On behalf of our team, we like to thank Dr. Sengutuvan sir, Dr. Karthik Prabhu, Dr. Sridhar, Dr. Abul Hassan, Dr. Sendil, and Dr. Anand. Altogether, under your leadership, we are able to achieve a very good number of nearly more than 200 doctors have become members of the Infectious Disease Certificate Fellowship course so far, and the 5th batch is on. I request all the 12,000 delegates and also another 1,000 more through YouTube to join this course. Till the 5th batch registration is still on. You can contact any one of us. You can contact me in this number and you can join the online course, 6 months course. With this brief introduction, with this thanks to the senior doctors of IMA, let us step into the first slide of today's topic. We are going to discuss about influenza. Friends, now the season is beginning. We are going to see lots of children and adults with fever. And this fever, we need to sort out whether it is bacterial or viral. If it is going to be viral, which is the virus? Just by attending this CME, you can just make a evidence-based diagnosis of what is the cause of fever and how to approach fever with applying your knowledge, what you have studied in your undergraduate curriculum, without doing any basic tests, just with proper history taking, spending few time with examination, proper examination, head-to-foot examination, you can come to a reasonable evidence-based empirical diagnosis, which is almost 99.9% correct without you even doing lab tests. So that is the main objective of this CME, which is going to be of higher standards, and there is no conflict of interest. Friends, you see lot of post-COVID, we see lots of viruses and bacteria that are roaming around in the entire globe, particularly down south in Tamil Nadu. We see lots of outbreaks of, now we do have outbreaks of human metapneumovirus, para-influenza virus. We have RSV virus that is topping the list, in particular young children. And we see resurgence of TB, scrub, leptospira, and other viruses. And of course, on and off, we do see Coxsackie-induced hand-foot-mouth disease in young children. And such a basket of viruses are circulating in the community. And my talk for the next 45 minutes is going to be focused on how to make a diagnosis based on your knowledge with 99.9% sensitivity and in your practice. So, friends, fever, which is a controlled rise of temperature, which is regulated by thermosensitive cells in hypothalamus, is a friend. It is not a disease. Please remember, fever is a manifestation of an underlying disease. Do not chase the fever. Chase the cause of fever. If somebody has got fever, if you give paracetamol and the fever is not coming down, if the adult or the child is day by day deteriorating, what you need to know is you need to make a diagnosis first and then treat the cause of fever. Do not treat the fever just by giving medicine one after another. Sometimes the parents keep changing the doctors, changing from one place to another place. Giving paracetamol first, they will go to medical shop, buy ibuprofen, then buy mefenamic acid. They will reduce the fever, but the underlying disease will be there. So educate your parents that fever basically is not a disease per se. It is the disease that causes, underlying disease that causes fever. You need to make a definitive diagnosis and treat the cause of fever. So fever is a friend. That's an important message. And do not aggressively treat fever by antipyretics one after another. Many of these antipyretics does harm, particularly in illnesses like flu or dengue, than doing good. So it's going to be case-based discussion today. Here you have a 7-year-old healthy child who gets a sudden onset of high-grade fever. At 8 o'clock, child was all right. At 8:30, child noticed to have 103-degree temperature, and the mother brings the child to your hospital from the school at around 10:30. So 3.5 hours back, child was all right. Now 103 fever, stepping into your chamber. So child also says that I'm not able to swallow, severe sore throat and dry hacking cough. Child looked tired. Child did not take food afterwards, has an nausea sensation, severe body pain, watery eyes, running nose, stuffy nose, all these things. This combo of these all 7 put together, you must know whether it is viral or bacterial. Should we prescribe antibiotic or not? So I'm going to tell you a simple 5-point rule which you need to apply in your day-to-day practice. Just by applying this 5-point rule, you can come to a reasonable diagnosis whether the present fever is bacterial in origin or viral in origin. If there is a sudden onset of fever in a previously healthy child, it swings the pendulum towards virus. You can ask me, why not bacterial? Bacteria have got long incubation period, whereas viruses ultra short incubation period. For example, influenza, it is 2 hours to 2 days. So suddenly within hours, child will get a high-grade fever. And more than one member in the family having fever swings the pendulum towards virus, because bacteria, usually they will give 1 week back, my grandmother had pneumonia. 10 days back, my husband had typhoid. So the incubation period is longer in bacteria, whereas because of ultra short incubation period, within a short time, in the same family, grandmother, father, younger child, more than 2 or 3 members in the family will be infected. If you look into the past history of pandemics like swine flu pandemic or COVID pandemic, millions of people throughout the globe pandemics are caused by viruses, not by bacteria. Within the house, 3 members, within the street, 10 members, within the colony, 100 members, within the city, 1,000, within the state, lakhs, within the country, millions, within the globe, billions, like that. Throughout the globe, it will be spreading. So viruses have got pandemic propensity. Similarly, viruses have got the hallmark of dissemination. Usually when a virus attacks the body, multiple sites will be involved. Eye will be red, throat will be congested, nose will be watery. Multiple sites involved, probably it is viral. Whereas in bacterial, there will be bacterial lymphadenitis. Only one cervical node will be enlarged. You can have bacterial tonsillopharyngitis caused by group A beta amyloid streptococci. Tonsils alone will be involved. You can have bacterial septic arthritis. Only hip will be involved. Whereas in viruses dissemination, multiple sites will be involved. At the same time, the same child, if you ask the mother what happened, ennama achin keta, she will tell that first நல்லா இருந்தான் சார், சடனா ஃபீவர் வந்துச்சு, உடம்பெல்லாம் பொறிப்பொடியா தெரிஞ்சு, இருமிக்கிட்டே இருந்தான், மூக்குல தனித்தனியா ஒழுகுச்சு, கண்ணு செவந்துக்குச்சு, தொண்டை முழுங்கவே முடியல, வாந்தி பண்ணிக்கிட்டே இருக்கான், தனித்தனியா வயித்தால போகுது, வரட்டிருமல் வருது. She will have a verbal diarrhea. When there is a verbal diarrhea from the mother, probably it is viral. Whereas in bacterial, only one system will be involved. Bacterial pneumonia. You can have bacterial dysentery. You can have bacterial UTI. So only one system is involved in bacterial. Whereas in viruses, multiple systems are involved. Last but not least, it is the interfebrile period, the period between 2 fevers. 8 o'clock, child arrived at your clinic, you gave paracetamol, at 9 o'clock, fever stopped, and at 3 o'clock, fever came back after 6 hours. Between these 8 o'clock, 9 o'clock, and 3 o'clock, 6 hours, from 9 to 3 p.m., the child was running about, playing, taking food. If the interfebrile period is normal, probably it swings the pendulum towards virus. If the child remains dull, fever congestion, sir, but என்னன்னே தெரியல, குழந்தை திக்கு திக்குன்னு மூச்சு விட்டுக்கிட்டே இருந்தான், சரியாவே சாப்பிடல, சோர்ந்து படுத்துக்கிட்டான், probably you're dealing with bacteria because of tissue hypoxemia. The underlying disease will be there, only the fever would have come down. So if there is a normalcy in between 2 fevers, probably swings the pendulum towards viral illness. So when you apply this 5-point rule for every febrile child that comes to your OP, you can make a diagnosis of simple short pyrexia, fever less than 7 days, nil localizing without any localizing signs. You can write probably viral. And you have to always, whenever you see a viral fever, most of the time these children can develop danger signs after the cessation of fever. You need to educate them about danger signs. The parents will be worried about fever, but you should. It's not the killer disease. Fever is a sign disease. It is a symptom of an underlying disease. You educate the parents about danger signs. If the child is sick, not taking food, the peripheries are cold, the child has got tachypnea or dyspnea, or the child has got severe abdominal pain, not taking food, persistently vomiting, or diarrhea, reduced urination, ask them to come back, even if there is absence of fever. This education about danger signs is the most important thing that we need to mention in our prescription. So whenever you make a diagnosis of short pyrexia, nil localizing, probably viral, 2 important things you need to note down is not to prescribe antibiotic. You must have guts not to prescribe antibiotic. During this viral season, during this monsoon season, particularly vast majority of the fever or viral nature, they do not require antibiotics. And always you educate them about danger signs. By educating about danger signs, you can reduce the mortality following these viral illnesses, particularly dengue, to probably 0. So that's the most important thing that you need to do. So having arrived at a viral illness, basically it is divided into respiratory and non-respiratory. Respiratory is mainly influenza-like viruses. There are around 7 viruses which I'm going to tell you later. Non-respiratory is illnesses like dengue. They come with a different set of presentation. So today I'm going to tell you about influenza. Influenza, if you look at this picture, both adults and children, they come to you with sudden onset of high-grade fever. Psychologically, they will have lethargy and lack of appetite. Many times, the symptomatology varies according to the age. I'll show you the chart where what age group, what are the symptoms of flu. By looking at this slide, you must know multiple symptoms: fever, sore throat, dry hacking cough. You can make a diagnosis of influenza. If what you have studied in your microbiology in your undergraduate curriculum, if you apply, you can even tell the virus influenza. You can even tell whether it is A or B. So if there is symptoms of nausea, vomiting, it's called gastric flu. Probably you're dealing with influenza A. If there is involvement of measles, myositis, probably you're dealing with influenza B. So you can even tell whether it is A or B just by applying what you have studied in your MBBS curriculum. So this combination of these 7 things, you can make a diagnosis of probably influenza. Short pyrexia, nil localizing, viral, probably influenza without danger signs. So what is ILI, influenza-like illnesses? It's the same symptoms exhibited by around 7 viruses. They are influenza virus, para-influenza virus, human metapneumovirus. Now there is an outbreak. And adeno, we had a couple of months back, lots of adenoviral infection, particularly in children. Now we do have RSV and rhino in western part, in Coimbatore, Bangalore, in Kerala, in southern Tamil Nadu, near the Western Ghats. We do have rhino throughout the year. And of course, this coronavirus, which is JN.1, now is becoming human coronavirus, and the symptoms are very mild and it is behaving like influenza. So these are the 7 viruses in our practice which are called influenza-like illnesses. Otherwise, in short form, it's called ILI. So if you look at the clinical features, in the younger age group, in children, the symptoms of more of fever, high-grade fever. Of course, non-productive dry cough is there. And most of the children exhibit sore throat. And the interesting thing is, many of these children do have abdominal pain, diarrhea, nausea, vomiting. And they present like gastric flu. Whereas in elderly, extremes of age, fever is not that classical finding. Headache, sore throat are not present in elderly. And abdominal symptoms are very rare. In elderly, it's more of nasal, rhinitis, running nose, nose block, with a cough, dry cough in elderly. Of course, in adults like us, it's more of a dry hacking cough followed by fever. Of course, we do have sore throat and more of congestion, nasal congestion. The abdominal symptoms are little less when compared to children in adults. So adults more of cough, children more of GI findings and fever. In elderly, more of nasal findings. This is from the Lancet. So you have influenza A, B, C, and C. C we don't usually consider because even in vaccines we don't have C. C is basically sporadic and limited to humans. It does not cause much of a disease. So C is not a problem. A is the culprit that causes pandemics. Your all Russian pandemic, Hong Kong pandemic, all your pandemics, swine flu, everything is from A. B, of course, is significant disease but limited to humans alone. Friends, influenza management is based on the category. So we have 3 major categories, and you must know in your practice, having diagnosed as influenza, you must write in your prescription whether it is a mild category A or a moderate category B or severe category C. All these 3, I'll tell you how you are going to approach a patient with this influenza. Category A is nearly more than 90%. It's a mild symptoms, and usually they come with all the symptoms which I mentioned. Here, what you need to do is, do not do anything, masterly inactivity. If you just wait and watch, symptoms will subside. Do not do any tests. Do not give oseltamivir. No need for antibiotics. Just home isolation. The child is going to school. Don't send for next 5 days. Just give paracetamol. The paracetamol dose is 15 milligram per kg per dose, not exceeding 80 milligram per kg per day. The co-prescription is ORS, preferably older child 100 ml per hour and younger child 50 ml per hour. Please remember, never give NSAIDs because of the fear of Reye syndrome. Use only paracetamol, paracetamol, paracetamol. There is no need for prophylactic antibiotic. Very, very important message. I'll tell you when you need to give antibiotics in a viral fever in the last slide. And definitely never use steroids, never give IM injections. Do not give injection to satisfy the patients. Sometimes, rarely, if it is going to be a provocative polio, just by giving the injection to a child with fever, you will lose a limb and you will lose your practice also. Never give IM injection. That's a very, very important message for general practitioners who are attending this conference. And always, whenever you see a child with viral fever, always educate them about warning signs and insist upon periodic follow-up. Because most of the time the parents are concerned about fever, and as fever will disappear, the danger signs will appear after the defervescence of fever. So you have to tell them, காய்ச்சல் குறைஞ்ச பிறகும் அறிகுறிகள் இருந்துச்சுன்னா காய்ச்சல் இல்லைனாலும் அவசியம் என்னை வந்து பார்க்கணும்னு சொல்லணும். That's very, very important that you must write black and white in your prescription with your signature, name, register number, date, time. This will save you in the court of law. Your education about warning signs. The countries which follow, smaller countries like Vietnam, Thailand, Malaysia, which gives warning signals to the parents, the mortality in viral fevers like dengue is practically zero. When all practitioners in our country, all the 1,000 doctors who are attending the CME, follow this simple rule, you can reduce your practice success to 100% and reduce the mortality to practically zero. Friends, as I told you, more than 90% are category A. Category A is a mild illness. Do not treat the child, do not treat the patient. God will cure, nature will cure. Do not do anything. Just wait and watch, everything will settle without any treatment. God will cure, the credit will go to the treating doctor. So next, let's come to category B. Before we jump into category B, whatever the viral illness, whether it is flu or a dengue or whatever the virus, COVID, you must understand these basic around 12 diseases that you need to keep in the back of the mind. Is the patient having chronic disease, neurological disease, or lung disease, heart disease, liver disease, kidney? Is the mother a pregnant mother? Or is the person immunocompromised either by disease or by steroids, drugs? Or does the patient has got asthma or COPD? Or is the patient suffering from diabetes mellitus or hypertension? Or is the child obese, BMI more than 40? Or extremes of age, children less than 2 years of age, adults more than 65 years. These 12 conditions are called comorbid illnesses. Whatever the disease is, when there is a comorbid condition, the underlying disease mortality, morbidity increases by 33%. For example, in pregnant mother gets flu, the mortality is very high, morbidity is very high. So you need to treat aggressively. Suppose a person with chronic disease develops a COVID, the morbidity and mortality is very high. A obese person, during our COVID time, we had lots of admission in post-COVID NICI in our hospital. We had all the children who had complications, who had developed multi-system inflammatory syndrome following COVID, that's called MESI. We admitted them, we kept them in our ICU, we ventilated them, we had prone ventilation. I remember we had children who were in our ICU for months together. So obesity is a very, very important comorbid condition. Please remember all these 12 diseases. Take a picture of this, retain it in your table. Whenever you get an illness with comorbidity, automatically, particularly in flu, any person with a mild symptom with comorbid disease, automatically they become category B. That is 8%. Previously, I told category A is 90%. This is around 8 to 9%. So it will come to both them put together, it will come to 99%. Category B is only 8%. In these 8% of the patients where there is a symptom with comorbidities, what you need to do is you have to start oseltamivir as early as possible. Oseltamivir, you should not misuse it. You should not give it for category A. You should use it only for category B. Category, you can do it without doing a lab test, RT-PCR. So no lab test is required. Based on a clinical judgment, you can start oseltamivir. And there is no requirement for admission. Just home isolation alone will do. So there is no need for antibiotics, particularly in category B. So let us come to category C. Category C is very, very important. These are the 10 conditions If the child or an adult has flu and they have tachycardia, tachypnea, dyspnea, hypoxemia, O2 less than, saturation less than 94, always have a pulse oximeter in your table along with your thermometer and stethoscope. For pediatrician, I would ask them to keep a otoscope also. So if there is hypotension, cyanosis, dehydration, drowsiness or dizziness, abdominal pain, seizures. If these 10 conditions are there, automatically a child or an adult with the flu becomes a category C flu, which is of course is only 1%. So 1% of the patients develop category C flu, that they have danger signs. This 1%, you need to do 6 things at the same time. On one hand, you have to give oseltamivir. Another hand, you have to take RT-PCR from the nasal swab. If you are having a clinic, please refer them. If you are having a hospital, admit them. You need to isolate them. You need to inform the health authorities. You need to treat and test, and all these 6 you have to do at the same time. Take RT-PCR, nasal swab RT-PCR. Give oseltamivir even before the results. Do not wait for the results. And these sick patients, you need to give broad-spectrum antibiotics, particularly IV, third-generation cephalosporin, like ceftriaxone, anticipating fatal complications like ARDS, pneumonia, pulmonary sepsis. So this is the only indication you need to give antibiotics in a case of flu, even before you get the lab reports. So the lab features are non-contributory. Your WBC will be normal, neutrophils will be normal. Sometimes you can have a bilateral symmetric infiltrations mimicking ARDS, like the picture X-ray you see here. We do see lots of elevated LDH, and the mortality is very high in a severe influenza, category C influenza, particularly when they got comorbid disease. So early treatment with oseltamivir, you can save these children and adults. So please remember when to start oseltamivir as early as possible, ideally within 2 days. But even if it is delayed, the New England Journal of Medicine's antiviral treatment should be initiated, even if it is delayed. So that's the most important message I want to give you. Ideally, say within 48 hours of the onset of symptoms. So coming to oseltamivir, you got a oseltamivir capsule that is 75 milligram, freely available in the government and private. You got oseltamivir syrup that contains 1 ml, contains 12 milligram. For pediatricians who are attending this conference, you must know this dosage because we do see young children coming with flu. The mother will have flu and the baby also automatically has flu. If the child is a neonate less than 14 days, oseltamivir, there is no evidence to use it for neonates less than 14 days. In that case, you can treat the mother with 75 milligram BD, ask the mother to give breast milk. Oseltamivir will be supplied through breast milk. If the infant is less than 3 months of age, you need to give 12 milligram, 3 months to 5 months, 20 milligram, and 6 months to 1 year, 11 months, 25 milligram. If you are treating the child, you need to give BD for 5 days, same dose. Suppose if you are giving as chemoprophylaxis for a period of 10 days, you need to give the same dose but OD dose. For older children more than 1 year, it is based on the weight. Less than 15 kilos, 30 milligram, 15 to 23 kilos, 45 milligram. You can take a picture of this. And more than 40 children and adults, the dose is 75 milligram, irrespective of the age or the sex of the patient. So 75 milligram for adults. So other antivirals that are available, though not in India, they are zanamivir. Usually I have given for one child who had a severe wheeze and not able to tolerate oral medicines. This zanamivir we imported from US and then we gave. It is available as an inhaler. It's given for children more than 7 years of age. Paramivir is an IV preparation that is also not available in India. I had this opportunity to use only in one child that was really sick in our ICU. We were able to get it from grey market and then give the child. We were able to save the child. So Paramivir for very sick children, particularly above the age of 2 years. And Baloxavir, it's a nucleotide analog recommended by Nelson textbook of pediatrics for children more than 12 years of age. So And the commonest question, $1,000,000 question is, many times I see prescription, நம்ம பயப்படாதீங்க சாதாரண வைரஸ் காய்ச்சல் தான், இந்த அமாக்சிலின் மட்டும் 3 நாளைக்கு கொடுங்க, இந்த அசித்ரோமைசின் 5 நாளைக்கு கொடுங்க. So when you make a diagnosis of viral fever, you must have the guts not to prescribe antibiotics. Please remember, most of the time, if you can prevent this antibiotic misuse from our prescription, from our end, we can reduce the development of antimicrobial resistance in our country. Please remember, the worst bacteria are identified from India, New Delhi virus bacteria. So it is our responsibility not to prescribe. In vast majority, as I told you, more than 90% of the fever in children particularly, and in also in adults during monsoon time, they are all viral, they do not require antibiotics. So when do you prescribe antibiotics? There is no role for prophylactic antibiotic in every viral fever, number one. And with the fever, there is a recrudescence of fever. Normally in flu, there is around 2 to 3 days of fever. By 4th day, 5th day, fever comes down. In dengue, you have biphasic fever, first 3 days fever, then absence of fever, second 3 days immunological fever, not infective fever. Then fever will subside by around 11th day. Dengue is 11-day illness. If the fever persists beyond that, if the fever persists for days or weeks, then probably disappears and comes after a couple of days, then you must think of probably a secondary bacterial illness. That's called recrudescence of fever, number one. Or a prolonged fever. Ideal fever in a flu is around 3 days, 4 days, maximum 5 days. The fever in flu, if it persists beyond 7 days or 10 days, then you can consider giving antibiotics. Or there is a deterioration, as I told you, category C flu, the child's life is at risk. You anticipate ARDS or fulminant sepsis or pneumonia, you can give antibiotics. Otherwise, routinely in your day-to-day practice, when you say viral fever, have the guts not to prescribe antibiotics. That's one of the important messages to all the 1,000 doctors who are joining this conference. So, and most of the time you see common cold, that is another child comes to you with common cold, particularly during this monsoon season. You must know to differentiate between common cold and flu. Common cold usually is a illness that lasts throughout the year, particularly in young children, particularly in preschoolers and schoolers. It happens for days, weeks, and months, and throughout the year. So usually common cold is gradual in onset, whereas flu is sudden onset. And fever is rare in cold, and most of the time it is sneezy or stuffy nose in common cold. But whereas in flu, it's a sudden onset of high-grade fever with severe body pain and headache, with less of a sneeze or stuffy nose, particularly in children and adults. More of an elderly disease in flu. So for common cold, what you need to tell them is, if you treat, the common cold will last for 7 days. If you don't give medicine, do not treat, it will last for a week. Ultimately, it's the same. Just reassure them, send them back without medicines. That will give more confidence on your practice, and also patients also will start liking you. They will, doctor kai totta podum, kai rasi doctor சரியாயிடுச்சு அப்படின்னு சொல்லுவாங்க. So you can make use of this, and then just keep educating every patient who comes to a clinic for minor illnesses like common cold, send them back without prescription. So if you look at the natural history of any disease, particularly influenza, as I told you, vast majority, more than 90% uncomplicated, self-limiting, no treatment, acute illness resolves by 2 to 5 days. So only thing is, cough will last for 2 to 3 weeks. So there is something called point of 2, rule of 2. Rule of 2 is incubation period is 2 hours. The fever lasts for 2 days. The cough lasts for 2 weeks. And asthenia, body pain in severe flu, lasts for 2 months. So this is called rule of 2. You can apply for influenza. These are all small things not read in books, but in your practice you can just use this. You can educate the parents by telling this rule of 2. So if you look at the complications, mainly pulmonary complications are more. Usually you have a primary viral pneumonia, usually looks like ARDS, it will settle down. Secondary bacterial pneumonia is only in patients who have got comorbid disease. And sometimes in asthmatics and COPD patients, worsening can happen. Rarely during monsoon, you can present as group flu. And sometimes some children come back to you with sinusitis, secondary bacterial or otitis media. The extrapulmonary is common, particularly when there is a category C flu. We have seen children who present to us with shock, multiple organ dysfunction, sometimes rarely coagulopathy and renal failure. And we do see often myocarditis and pericarditis in young children. Encephalitis is though rare, particularly during this monsoon time, we do see children coming to us with febrile seizures. Nearly 25% of the febrile seizure during flu season is because of the flu. If you take the history properly, there have been somebody in the house having fever, a similar picture of flu, the child presenting with high-grade fever and throwing seizures. So, vast majority of them are due to flu. And sometimes we do see children who've been brought to our examination couch by lifting. They have severe myositis. If you do a CPK, it'll be raised to hundreds, not like thousands in other congenital disorders. So myositis, as a rule, it settles down within days. So rarely drug-induced Reye syndrome is common. Never prescribe any other drug other than paracetamol. So coming to vaccines, this is a most sought often question from the doctors. In vaccines, there are two vaccines available currently in the market. One is called a live vaccine, another is called attenuated vaccine. Live vaccine is a nasal spray vaccine which is given above the years of 2. Since it's a live vaccine, it is contraindicated in pregnancy. Now, the vaccine that we are using, the IM vaccine, is called inactivated vaccine. So it's given for children above the age of 6 months. Up to 6 months, you have maternal antibody circulation. It's this inactivated vaccine can be safe in pregnancy. The dose is from 6 months of age to adults, the same dose, 0.5 ml. Irrespective of age of the child or the weight of the child or adult, it's the same dose, 0.5 ml IM. When you are giving for children below 8 years of age, you need to give 2 doses. 1 dose now, 4 weeks later, another dose. For all others, more than 8 years and adults, single dose. Please remember, annual dose is important because these viruses, particularly flu virus, has got antigenic drift. Every year, new strain comes to us. In our hospital, our hospital is a sentinel. I'm a sentinel doctor for WHO, World Health Organization. We take samples of children who come to us with influenza-like illness. We send it to Guinea. From there, it goes to NAB Pune. From there, it goes to CDC Atlanta. From there, it goes to WHO. They know what virus is going to come in, particularly in Coimbatore, South India this year. So every year it keeps changing. And what the inputs we give throughout the globe, there are more than 162 sentinel doctors. From data collected from everywhere, it will be put together and analyzed, and the particular strain vaccine will be manufactured every year. So sometimes there will be a major antigenic shift in which you get a pandemic shift. So flu vaccine can be concomitantly used with other vaccines. In ecology, you can use it, but with caution. You have oxygen, hydrocortisone, adrenaline ready, and then give the vaccine. So ideally, it's a vaccine to be given to all above 6 months of age. But in practice, particularly for pediatricians, for children above 6 months up to 59 months, and then up to 4+ years. For adults, elderly, preferably in India, we recommend above 50 years. But in practice, above 65 years, you need to give this vaccine. Who have, as I told you, those comorbid conditions like chronic disease of the lung, heart, kidney, liver, or if they are immunosuppressed, or there is a pregnant mother. All these conditions you need to give, obese persons, you need to give flu vaccine irrespective of the age and the other criteria. Here I'm going to give you a child who comes to you with 3 years old child with same picture, but this child has got conjunctivitis and mother says child has got reduced urination. So this is the same flu-like illness which happened a couple of years back. I'm sure many pediatricians who are attending this conference will know, would have faced such thing. Viral-like illness with conjunctivitis and reduced urination. This is nothing but your adenovirus. A combination of respiratory plus GI plus eye plus urinary symptom is, until proven otherwise, is adenovirus. So please remember, This will mimic like a pneumonia resembling bacterial illness. Sometimes they can have watery conjunctivitis. Whenever you have a conjunctival involvement, look at the cornea. If there is a corneal involvement, refer to early to ophthalmologist to treat keratitis. And many times you have sterile pyuria. Like we today we had a child with sterile pyuria with 15 days fever, turned out to be Kawasaki. So sometimes you can have hemorrhagic cystitis in adenoviral. We have met severe children with severe adenoviral illness. Those children, we used a drug called Cidofovir, imported drug. We have saved those children. And we have used IVIG, some children who had a severe adenoviral illness with severe hypoxia and shock. So please remember, adenoviral illness is very, very important illness. If you have eye plus respiratory symptoms with hematuria, think of adenovirus. The most important thing is post-adeno, you can develop fungal sepsis wherein you can have a hyperlucent lung. But please keep that in the back of the mind. But for practice, you need not worry about that. So many times you see children presenting you, the fever would have settled down, but cough is there for weeks. They come to you for cough. So what is the evidence-based recommendation of a cough syrup? So please remember, as per Nelson textbook of medicine, avoid cough syrup in children less than 2 years. Then what to use? I am going to tell you another simple home remedy for children with cough for less than 2 years. Please avoid cough syrup that contains antihistamines, decongestants, bronchodilator, cough suppressants, all having different action put in a single bottle and nothing will act. So never have polypharmacy. When you prescribe a cough syrup, it should have only one ingredient. Please remember that. So for a common cold, for a young child, please prescribe first generation antihistamine. This crosses the blood-brain barrier, gives a soothing relief not only to the child and also to the mother. You can use diphenhydramine. The dose is 5 mg per kg per day. You can use it 6 hourly. If there is an isolated dry cough, nothing other than that, you can use dextromethorphan. Dose is 1 mg per kg per day. Do not use codeine. So, and if there is an allergic rhinitis and there is a post-nasal dribbling in a child who is going to school, if you use first generation antihistamines, it will cross blood-brain barrier, it will affect the scholastic performance. You can use second generation antihistamine like desloratadine or levocetirizine or fexofenadine. If there is a chronic afebrile cough, night இருமல் வருது, படுத்தா இருமல் வருது, டே டைம்ல கம்ப்ளீட்டா இல்ல, ஸ்கின்ல குழந்தையா இருக்கும்போது ஸ்கின்லாம் ட்ரையா இருந்துச்சு, ஃபிளக்ஷஸ்ல எக்ஸிமா இருந்துச்சு, ஃபேமிலியில அவங்க அம்மாவுக்கு ஆஸ்மா இருந்துச்சு, இந்த மாதிரி இருந்துச்சுன்னா you can give plain salbutamol. You can do one thing, you can give a nebulizer of salbutamol, a single nebulizer. If the cough settles down immediately, that is a therapeutic test. You can prescribe them salbutamol, the cough will come down, they need not come back to you at all. But the only important thing in a chronic afebrile cough, probably it is hyperreactive airway disease. You need to educate them about prevention of triggers. A simple a cough of months together, with your simple advice, the cough will settle down without medicines. For example, ask them to stop that mosquito repellent. Ask them to avoid this panjamathai, ilam panjamathai. Panjamathai contains lots of mites that be a respiratory trigger. So keep these things in the back of the mind. For children less than 2 years of age, honey is the best demulcent antioxidant, which increases the cytokine release and it has got an excellent safety profile. This is recommended by pediatric clinics of North America, American Academy of Pediatrics, WHO. Dose is 2.5 ml to 5 ml HS with warm water, or around 10 to 15 ml of water. Though it is not recommended for children 1 year of age because of the fear of botulism. Always use pasteurized honey. So let me go to the last slide. So whenever we see a child with a cough, fever, most of the time we tend to do some investigation. Never take an XHS unless the child has, you suspect pneumonia. For a cough, do not do XHS because cough is because of the irritation of the respiratory centers or in the bronchial wall. So it is a luminal pathology. You have to take X-ray only for parenchymal pathology like pneumonia. So never do XHS. If at all you do a CBC, always most of the time in viral, the counts will be preferably most of the time normal, or there can be a leukopenia. Sometimes in some of the virus there can be thrombocytopenia. Suppose these 4 conditions, you can look at the CBC and you can take a picture of this. By looking at the CBC, you can make a diagnosis whether it's a common viral illness, respiratory illness, or a dengue having thrombocytopenia and a high hematocrit, or a malaria having high eosinophil count monocytosis. For making a diagnosis of enteric fever, the total count may be low, but the main catch point here is you have to look at the eosinophils. When you look at the Coulter count, you have to look at the monocytes. If there is monocytes are 0 or 1, if there is a eosinopenia, think of enteric fever. This is a secret for infection disease. Those who attend this such. So we are conducting this infection disease certificate course, which is still on. The registration is still on. You can contact me through the number last slide. So friends, antibiotics in vast majority, more than 90% of simple febrile illnesses do not require antibiotics. In less than 9%, if you prescribe antibiotic, only 3 antibiotics in your practice. For supradiaphragmatic infection above the diaphragm, mainly gram-positive organism, use simple amoxicillin. For infradiaphragmatic infection below the diaphragm, gut and urinary tract infection, use only cefixime. Do not use cefixime for upper respiratory or lower respiratory infection. For skin and soft tissue infection, use only first generation cephalosporin. Only 3 antibiotics in pediatrics, the 2 only in less than 9% of the patients with fever. 91% do not require antibiotics. That's an important message. So for doctors, practice washing your hands off face, practice cough at duty. Getting vaccinated every year for doctors is very, very important, particularly for flu. And the most important carry message is 91% of flu are mild in nature. They are called category A, no test, no result. 1% test, treat, admit, isolate, and intimate authorities. So with this, let me come to the last slide. Please note down my number. Please take a picture of this and you can call me or send a WhatsApp message. So for the joining this infection disease certificate course, which is run by IMA CGP TNSC, I once again take this opportunity to thank all the leaders for this excellent CME programs that's been happening in Tamil Nadu. I think my special appreciation to Sendil and Anand for having a record of more than 2,500 doctors registered for this conference. So with this, thanks. I'd like to thank all the delegates who have joined. So thank you one and all. If there are any questions, I'll be happy to answer at the end. By following me, Dr. Raghunandan, Professor of Medicine, Madras Medical College, will discuss about hepatitis B. He is a core member of this certificate course. And following him, Dr. Suresh Kumar, ID specialist from Apollo, will discuss about typhoid fever, which is also monsoon illness. So these are all commonly seen in our practice, but less frequently discussed. So I request all the doctors to note down my number and contact me through WhatsApp for joining this very, very important infectious disease fellowship course, which will be enhancing your practice and which will be of benefit to all the patients who attend your clinic. Your knowledge empowerment, skill empowerment will not only save your practice, save your patients also. With that, I'd like to once again thank for giving me this opportunity.
Thank you, sir. Thank you for the amazing presentations on the flu. The case-based approach is really the need of a practitioner to know how can we react during the situation, and it's very well explained and on the core areas. Thank you very much. Now we will move to the second presentation by Dr. Raghunandan sir. So sir, Dr. Raghunandan sir is Professor of Medicine and he is now heading the research wing of University. Sir, can you hear me?
Mohan,
Raghunath sir?
Mohan, before Raghunathan sir comes, you can just say a few words about fellowship. Yeah, you can just say about our course and then before he comes, please.
So that is the right? Every organism wants to live in this world. Survival of the fittest is the way we know. Before the invent of infectious antibiotics, we know that okay, infections, bacteria, and pathogens are going to kill us. Once we got the antibiotic, way before in 1900, so we thought that okay, we will win over the infections. Okay, but still there are a lot of bacteria killing again and again, and we not sustain because there were a lot of resistances, new bacteria coming, antibiotics not working. Then we grew in the second level called vaccine. So we were even one step ahead to prevent it, right? We had a lot of vaccines. Again, we are saying now we can avoid diseases and go. But still, vaccines could not sustain. We don't have access for all the infections, all the bacteria and viruses. But as and when we grew our knowledge, we had antibiotics, we had good treatment, and infections are mostly nil. And we have to focus not on communicable diseases, but the HIV has turned the infectious diseases into a paradigm shift, and again, it's an fulminant infection across. And even after the globalization, urbanization, and all these actions which we felt in the modern world, the world became very small, and transmission of infections from one area to
Mohan
another.
sir, your voice is break. Mohan sir, your voice is breaking.
Okay, sir. Yeah, maybe can you now? Okay, let's go and wrap up. What I was trying to say is the modern world, the infections are dominating us, and every year or alternate going, we are having big outbreaks, big viruses, and we have now interactions between animal and the human. So doing about infectious disease, refining ourselves is very, very important. Whatever we learn in textbooks, we have to actually relearn and do the updations on a regular basis. So I request that whether you join here or join a course, come and do FCIDs or do any other courses of communicable disease, of courses in IMA. Always keep yourself updated on the subject of interest to serve the country. That is the goal of IMA. That is the goal of IMCGP here. With that words, I call Dr. Raghunath sir. Dr. Raghunath sir, can you hear me? Raghunath sir. Let me check with him. Yeah, give us a minute. Sir, host sir, can you make Raghunandan Srinivasan sir as a co-host, please? And also, we can allow him to unmute.
Am I audible now?
You are, sir.
Am I
Yes,
audible?
perfect. Yes, sir. Can you make it a
Slides are
slideshow, please?
Visible?
It's visible, sir. Can you make it as a slideshow?
Slides தெரியுதா?
Slide 3 sir, slideshow பண்ணனும். It is so in the editable mode. Yeah. Stop share and then share the show slides. Show, sir.
stop share போயிட்டு திருப்பி வரட்டுங்களா?
Yes, sir. Stop share. And then share the screen with the slideshow. The full screen slide. அது வந்து share பண்ணணும். இந்த view. நீங்க பாத்தீங்கன்னா ரெண்டு view வந்து உள்ள. ஸ்லைட் ஷோ பண்ணுங்க சார். ஸ்லைட் ஷோ பண்ணுங்க.
Is it okay now?
Sir. No. Sir. If you share, there are two types of slides. My side order, the slide மட்டும் இருக்கும். You have to show that show and select that screen.
Multiple participants.
Share. And in the windows, only you will have this World Hepatitis Day full slide. Inside that window.
Sir, slide தெரியுதா இல்லையா?
தெரியுது, but ஆனா slide showல தெரியல. Can I send it to me so I can do the slide show?
Just 1 minute, sir. 1 minute. Slide sharing அவங்களுக்கு தெரியலங்கிற one second.
Yes.
நான் இதுல வருது அவங்களுக்கு வருது. சார் சொல்லுங்க சார் இப்போ.
Stop share and then slide show. Share the slide with the slide show. Yes.
இது பண்ணுங்க.
இல்ல அவங்களுக்கு நீ ஷேர் பண்றது
தெரியல. Full screen வரணும்.
Full screen. Like I said, entire screen and then share.
இப்ப தெரியுதா சார்?
Same. Can you make a slideshow, sir? Click the slideshow.
Full. Just a yeah. Are you able to see now?
No, sir.
இல்லையா? Options close பண்ணு. Stop share பண்ணு. Stop share பண்ணு.
Click the share button, sir. There will be two windows. On the top left, there is a screen. Select the screen. Yeah, if it is. Now it is perfect, sir. Yes, I was expecting this only.
Full screen தெரியுதா?
Over to you, sir.
Yeah.
Yes, sir. Perfect. Over to you.
Yeah. So, good evening, all. First of all, I congratulate Indian Medical Association College of General Practitioners for arranging such a wonderful annual conference today. And before I go to my topic, again, as Dr. Neminathan and Dr. Mohan Kumar was mentioning, you may be aware that we are conducting an online infectious disease certificate course program, which is well received by many of the doctors who are in the family medicine practice. One of the unique feature of this program is even though we have the core team of specialists, for every topic, we make sure the expert in that particular field with vast experience takes that topic, and we have a lot of panel discussions, question answers, and other things. And also, you will be receiving the certificate in the annual conference of College of General Practitioners. I'm 100% sure that this will be influence your practice and improve your practice and practice as per the latest guidelines available, not only from WHO and other international organizations, as well as from national and state governments. So I once again request, and now we'll go to my presentation. In fact, when the topic was given as viral hepatitis to me, I was, one second, sir. Yeah. When viral hepatitis was given to me, I was really happy for many reasons. One of the reasons is this month, July 28th, is being observed as a World Hepatitis Awareness Day program. And as far as this disease is concerned, it's emerging as a very, very major public health problem throughout the world, and in particular in India with so much of population. So as far as handling this silent epidemic, I would call it as, we need the cooperation of not only the government as well as the private doctors who are watching this program. Together, we should be able to control and eradicate viral hepatitis. The target year 2030 is the target set. So with that small introduction, I'll go to my presentation. The outline of my talk is why we should learn about this viral hepatitis, what is its relevance and significance, and we'll have some case scenarios, 5 case scenarios, which we come across commonly in our day-to-day practice. For that case scenarios, what is the algorithm of lab diagnosis? Again, how to assess the severity of liver disease, because that determines many times whether to initiate the treatment, how to monitor these people for long-term follow-up, and of course, what are the medications available, antivirals at our disposal today, including the preventive aspects. So these are my outlines. So I'll just go to some interesting statistics, which all of us as family physicians should be aware of. As I said, 28th July is observed. And for this year, the theme for this year is, let us break it down. What we mean by break it down calls for an urgent action to dismantle the financial, social, and systemic barriers. When I mean financial, because you know the cost of antiviral drugs are very expensive, but today we have to thank the Government of India and Government of Tamil Nadu for making this available free of cost in all our government institutions. And in fact, Government of India, Ministry of Health and Family Welfare has brought out a very good national guidelines. All my presentation today are based on our national guidelines. Again, I request all the learners who are attending this program to go through it later also, because one of the important program which needs uniformity in our approach to management of our infectious disease is viral hepatitis, that you will appreciate in subsequent slides. So it also the stigma of that we have to create awareness and make it aware that it can be a problem, but it can be controlled or cured. And of course, 2 important complications that we all know about hepatitis B and C, especially when it goes to chronicity, is cirrhosis and hepatocellular carcinoma. So in fact, when this topic was given to me, the last 2 or 3 months, I managed two cases of cirrhosis of liver in my practice. You know, in India, anybody, especially when a male comes with cirrhosis of liver, we know it is alcoholic unless proved otherwise. So we always assume that cirrhosis is always due to alcohol. But 2 of my patients, one was a female and other was a male, who really denied ingestion of alcohol, and both of them turned out to be hepatitis B positive. The unfortunate thing is we diagnosed hepatitis B in these 2 patients who had cirrhosis only after they developed cirrhosis. So we should have done it early. We have allowed them to progress to cirrhosis. So that is where I said this kind of CME programs will create awareness among our doctors in picking up these patients early, and the algorithm we'll discuss later. So it can, despite being preventable, it is treatable. And in the case of hepatitis C, it is curable. It's the most interesting thing. So we have to scale up and integrate hepatic services, starting from vaccination, which we'll discuss later. As a practitioners, we have to create awareness on safe injection practices, harm reduction, especially on testing and treatment. So these are the 3 important points WHO has brought in to disseminate, not only for doctors as well as for the patients and public in general. It affects almost 1.3 million. Chronic viral hepatitis affects 1.3 million. It creates deaths every year, mostly from hepatocellular carcinoma or the cirrhosis. An alarming 3,500 deaths occur every day, on par with TB. Both are spreading silently. That's what I was mentioning. It's a silent epidemic with almost 8,000 new infections daily. Despite being preventable and treatable, this continues to be a very big burden. Next important point is knowing your status is a first step to stopping liver cancer. I think, friends, all of us know of recently, in fact, we are picking up a lot of hepatocellular carcinoma also, and mostly they are BRC driven. So most people living with hepatitis don't know they are infected. That is where the early diagnosis is a first step to accessing life-saving treatment. So it is very, very important to screen all the people. Also, I would strongly recommend to whether they harbor the hepatitis B or C antigen without symptoms or signs. And we can prevent 2.8 million deaths by 2030 only if countries act now. So again, this day I dedicate my talk, in fact, to Dr. Baruch Bloomberg. When I went through his history, he's such a great scientist who lived in US, and his birthday is being observed. 28th July is observed as the World Hepatitis Day. So one of the unique thing that he carries is he not only discovered the hepatitis B virus, but he developed the diagnostics test, and most important, he also developed the vaccine. So noi kandupidichore adukuna diagnostic vaccine prevention. Maybe if you would have lived longer, you would have found the antiviral drugs also, I suppose. So these are the three important things that is, let us break it down. And these are the current statistics, looks very, very alarming. Okay, so far we saw about the global statistics. Now, before I go to the management of our problem, let us look at Indian statistics. The HBs positivity, the different studies start somewhere between 1.1 to 12.2%. As far as hepatitis C virus antibodies prevalence is concerned, 0.09 to 15% is the prevalence of this infection in our country. When you convert into absolute numbers, almost 40 million are chronically infected with B, and around 6 to 12 million are infected with C virus. Okay. So after learning why we should know and we should be aware of this and its relevance in public health practice, now I'm going to discuss 5 case scenarios. I'll read out all the 5 scenarios so that as the presentation moves on, I'll try to correlate with this case scenario. So the first one is, I think, most common that we come across in our practice. A 10-year-old boy has come to OPD for complaints of jaundice, and he has got traditional symptoms of fatigue, tiredness, anorexia. And few days back, he had some mild fever with upper respiratory syndromes, and now is also passing high-colored urine. I think all of us know the straightforward diagnosis is a viral hepatitis, most probably, and again, most probably it could be a virus A type. So again, all of us know, just a quick recollection of little bit of microbiology. We know at present 5 important viral hepatitis viruses are there: A, B, C, D, and E. Always A and E go together. Both are fecal-oral spread, and most of them, both of them are self-limiting. And only one unique feature for the hepatitis E is it common among the pregnant women, and both can cause sporadic or some outbreaks. So usually when there is an outbreak of jaundice in a hostel or in a crowded place, always we should rule out A or E. So that is obvious diagnosis, will come again later. Next case scenario which we come across is again common scenario: 20-year-old healthy adult who went for blood donation, who went to blood bank for donation, and his blood was tested and found to be HBs positive. And he has now come to your clinic to know what should he do further. We'll keep that scenario. Again, the third, which I again recently managed, was a 44-year-old lady, was non-alcoholic, was admitted for evaluation of chronic liver disease, and she has clinically features of cirrhosis of liver. Again, how will you proceed? Because he has got a hepatitis B investigation was found to be positive. Again, another most important topic is antenatal mother. Why I am stressing the hepatitis and anti-mother is very, very important, especially for hepatitis B. Friends, please remember perinatal transmission. What I mean by perinatal transmission is at the time of delivery, if a hepatitis B positive mother delivers, she can transmit to the baby. So what? Today, if you look into the community that I was mentioning about asymptomatic prevalence of hepatitis B infection in the community. So if somebody is harboring the virus, the statistics on the science says 90% of them, 90 have acquired through perinatal transmission. Only 10% is due to other modes, which we all of us know, through blood pricks, IV drug abuse, blood transfusions, or sharing of needles, all those things, sexually transmitted, all those things. So the most common source is for hepatitis B, it is perinatal transmission. So that is why government has gone a big way of screening all AN mothers, even during the first visit itself for hepatitis B, and also making sure the protocols of delivery and screening the baby and giving the vaccination, which we will discuss later. So the final scenario, again, a 30-year-old male, again, now the drug abuse you will be seeing in media. The incidence is going up. IV drug abuse is becoming a big menace in our country. So somebody is found to be having hepatitis C positive. Again, friends, we know as far as C is concerned, the most common is the IV drug abuse and blood transfusion. But when it comes to B, it is perinatal transmission. So just keep these 5 scenarios. These are the background of my presentations. As we evaluate the cases, we'll try to correlate with these case scenarios. So we were talking about first about the hepatitis A. Again, they have around incubation of 4 weeks. Again, the most important and critical thing is it's a self-limiting infection. Again, you can see it is a fecal-oral spread, and you can see the viral load in the viral, stools goes up and comes down, and the patient develops 2 types of antibody, one IgM and IgG. So if you want to diagnose a viral hepatitis as whether it is due to A, we have to do a blood test for IgM. Again, all of us know IgM shows the acute infection. And once the IgM settles down, again, you will have the lifelong protection of IgG also. It gives the protection. As I said, it's a self-limiting. So these children or adults, they need only symptomatic and supportive care. Monitor the liver parameters. The enzymes may go up to 10 times upper limit of normal. Rarely, less than 1% can go for acute liver cell failure. So when we know they are going for acute liver cell failure, worsening of jaundice, bleeding tendencies, hepatic encephalopathy, and they can go for hepatorenal syndrome also. So as far as evolution of hepatitis A is concerned, they are self-limiting. So wait and watch and monitor. Otherwise, of course, preventive measure is, as it's fecal-oral spread, we have to be cautious on the hand hygiene and other things, and we can go for vaccination. Again, now we'll come to hepatitis B. I think I want to spend more time on hepatitis B because it is such a unique disease. Really, we should understand the pathogenesis or the natural history of this disease, because there are 4 important phases you can see in this particular when whatever we want to apply in our practice, our knowledge and understanding must be proper. Then only we can able to apply in our clinical practice. So I'm not going to confuse you with all the points what is being mentioned. As I said, it is available in the website. You can go it later if you are interested. Just I want to tell you the progression of the illness, because if somebody is hepatitis S positive, he can present to us at any point of life. That is what this slide is trying to explain. So if you look into the slide, it is first phase is called as immune tolerant phase, where the patient has got hepatitis E. Again, before I explain this slide, I'll explain one more basic points just to refresh our knowledge. As far as hepatitis B is concerned, we have got 3 antigens. So one is called the surface antigen, and we develop antibodies against the surface antigen. So both antigen and antibody are detectable. Next is we have the core antigen. Core antigen is inside the thing, but we cannot pick up core antigen in the blood. So we can only detect the antibody against the core. So we can do only antibody against core, C antigen. And finally, again, E antigen, all of us know presence of E antigen shows infectivity. If somebody carries E antigen, that means they are highly transmissible of this virus to others. And again, you can pick up antibody against E antigen that shows that person is protected from transmission. So we have got 3 antigens and 3 antibodies, but except one antigen, we can measure all the other 5. So this is a basic understanding that we should keep it in mind. Again, coming back to this particular phase, again, you can see there are 4 phases. First phase is called as immunotolerant or immuno. Next phase is called immunoactive. Then we have the inactive phase, or where your immune system is under control, and sometimes you may go for reactivation. So let us not go into everything. Just I'll read out the last component that if you understand. So this phase, that there is minimal inflammation, up to 20 years it can be there. This phase is seen in transmission at birth. That's what I was mentioning. Patient acquires or the child acquires at the time of birth. HBsE will be positive. That means they are highly transmissible. They have a high viral load. And there's no elevation of enzymes and other things. So they don't have any immunological response. So simply they carry the virus. They are transmissible. They have the viral load. They are able to tolerate. Then they go to a clearance or active phase where increased immune response to this virus occurs. So because of antibody response, your viral load comes down, enzymes will fluctuate. So this active hepatitis can go up to the age of 35. So they say up to 20 it is tolerance, then up to they can react to that. Then later up to 60 they can be in a immune control phase. That means even though they are having the antigen, they may in a control phase. Rarely they get reactivated. That is why they call it as reactivation. So if you just simply understand that the virus that is present in our blood, how our immune response to the virus determines the clinical presentation, complications. So we have to understand this natural history. So now, as I said, mostly they can be asymptomatic. Rarely they can go to fulminant hepatitis. And 70%, that's most important, 70% are anecric, and many of them are picked up by casual master health checkup or blood donation type. Then how do you know? Suppose if you know somebody is positive, how do you know they are progressing towards some chronic complications? One of the 2 indicators is decrease in WBC, decrease in hemoglobin, and decrease in platelets because of hypersplenism, or again, decrease in the albumin, prolonged prothrombin, and INR because of the synthetic functions of liver is going down. So again, there we have to understand the difference between when you say acute or when you say chronic. So when the completion of resolution of symptom doesn't occur, it progresses. Again, you know it's going for chronicity. When you do a biopsy, if they have a necrosis, again, failure to return of normal enzymes or bilirubin and globulin within 6 to 12 months. And most practical thing will be persistent of E antigen more than 3 months or S antigen more than 6 months. So practically, we can know that if somebody is having a hepatitis S antigen positive and continues to be positive for more than 6 months, we can label them as chronic hepatitis B infection. Okay, so now we'll come to assessment. Suppose, as I said, somebody, a blood donor is found to be positive, or given a cirrhosis patient is found to be cirrhosis, definitely we have to start antivirals. But on other investigations, they found to be positive for hepatitis B. How to go about this? So we have to measure. I always believe in 4 or 5 checklists. I always use what to ask for, what to look for, what to test for, then how to treat, and when to refer. I think if you ask a family physicians, if you keep these 5 mantras, what to ask for, what to look for, what to test for, and how to treat, and when to transfer or refer. So again, somebody comes with a high risk behavior, hepatitis B positive, always ask whether the mother was found to be positive, whether that fellow was vaccinated for hepatitis B vaccination, whether he had any high risk behavior. All this relevant history is very, very important. Again, as far as clinical examination, they may or may not have interest, but usually they have hepatomegaly. And if they are progressing towards cirrhosis and other things, they can have a splenomegaly also. And again, other complications of cirrhosis, they may have thing. So most important thing is we have to do the liver enzymes, which is very, very important. Then we have to assess, there's another two important tests that we have to keep it in mind. We call it as non-invasive test, that is called as APRI, that is aspartate aminotransferase to platelet ratio index. Because today the management of any viral hepatitis, especially B and C, depends on these 2 or 3 important parameters. So later we are going to use these parameters to decide whether to start antiviral or not. So one important parameter is APRI, that is aspartate aminotransferase to platelet ratio index. Next is FIB4. Again, we'll come to that. What is that FIB4? Then transient elastography. I think today fibro scans are becoming very, very popular, just like ultrasound, where you just only measure the liver size and other things. We have a fibro scan which can assess the elasticity of the liver. And again, there is a DNA load. This is very, very important. It's a little bit expensive investigation, but as far as treatment is concerned, this is one of the very good parameter to know, not only to decide on the treatment to start or not, but also to know whether the patient is responding or not. Plus, finally, if liver biopsy is available, we can plan. So apart from that, you should do the routine hemogram also. So what to test for? Make sure that the viral markers are done, viral DNA if needed. Most important are the liver enzymes, NITs, and fibroscans. So all these things again, it's being repeated. And later, one more thing we can do is the alpha fetoprotein also has to be done. Okay, I mentioned about 2 important tests, APRI, that is AST to platelet ratio index. How they calculate, you can see in the thing, how they calculate is AST by upper limit of normal. That means we can take it as around 20 to 30 international units into 100 divided by platelet count 10 to the power of 9 per liter. So this is a formula, but today we have a app. Once you put the value, it gives a score. Next is the FIB4. I was mentioning of FIB4. That is age in years into AST in international units divided by platelet count. And don't worry about this formula, but there is a formula. And as I said, the apps are there. It will give you the values. So we have to calculate APRI and FIB4. So the normal score is APRI must be less than 1 and FIB4 must be less than 3.5. So just remember that. So, sorry, 1.5. So we have got the cirrhosis, METFIB F4 and METFIR F2. These are some calculations. Similarly, for fibroscans are also some calculations. I will not go into the nuances, but just remember these are some parameters which is used to decide. Then, as I mentioned about the liver biopsy, it may not be done in every case, but in deserving or indicated, definitely we should assess the thing. That staging is called as metafit staging, which goes from F0 to F4. Okay, and finally, because why I'm mentioning all these scores, this is the background on which your algorithm of treatment of viral hepatitis is determined. And finally, this is assessing the progression of the liver cell failure. Child-Picks score, I know most of them may be already knowing, and they classify into A, B, and C, and the points are there. More than 10 points is definitely a severe phase. Okay, now we'll come to the treatment schedule. As I said, today, Government of India and Government of Tamil Nadu have come out with a separate program for hepatitis B control. We call it as the National Viral Hepatitis Control Program, NVHCP. And the ambition is to eliminate viral hepatitis by 2030. So these facilities are available, including in block primary health centers and all the taluk and medical college hospitals. So this is a flow chart of how the initial screening is done. So patient is screening for hepatitis B and anti-HCV, that is for antibodies against the HCV. Okay, so we divide them into, it can be negative or it could be positive. If it is positive, then you refer for a viral load, as I already mentioned. It's one of the indication for viral load is to decide on the treatment. So this is a very, very simple formula. We are classifying viral hepatitis without jaundice. That means accidentally they are screened without jaundice, B positive or anti-HCV positive, then you report as mentioned. Again, this is a general algorithm for any viral hepatitis in a jaundiced patients, because this is where most of our patients come to our OPD. They come with some jaundice and constitutional symptoms, how to go about it. Now you can see the four parameters that has been used. First is, as I said, for hepatitis A virus, you do the antibody IgM. If it is reactive, you know it is positive. If it is negative, you say negative. Then E antigen, hepatitis E virus, you find out the antibody against the E virus. If it is reactive, you can say E virus is positive. Similarly, B, you have S antigen and antibody. So these are all interpretation of the blood reports. So I will not go to the nuances, but you can just check it up later. Again, the same thing for a E positive, they are given chronic infected hepatitis. The algorithm is there. For want of time, I'm not going to the nuances. We'll focus on the treatment later. Again, this is for a negative, hepatitis B negative. So again, once again I repeat, whenever a hepatitis B is positive, we can do around 5 tests: hepatitis S antigen, hepatitis E antigen, antibody against HBs, antibody against C, antibody against E. So these are the 5 tests that is done, plus viral load, plus the 2 scores what I have already mentioned. So we'll come to the most important part of this particular hepatitis B problem, whom to treat and when to treat. It is critical to evaluation the patient carefully, which I already mentioned. Then we'll go to what are the indications, whom to treat. As a priority, all adults, adolescents, and children with chronic hepatitis B and evidence of compensated or decompensated cirrhosis. So the first indication is if anybody has got cirrhosis and hepatitis B positive, immaterial of other things, they have to be started on antiviral. So this is the point I was telling. At present, we are picking up cirrhosis, then hepatitis B positive. In fact, we should be able to pick and screen them before they go for a cirrhosis. So treatment is recommended for adults with chronic hepatitis who do not have evidence of cirrhosis, but they are aged more than 30 years and they have persistently abnormal ALT levels and evidence of high HBV replication, that is the viral load, the indication, the cutoff value is more than 20,000 per international units per ml, regardless of HBE status. So I think these are the 2 very clear-cut indication. Here we'll come to whom not to treat. Antiviral therapy is not recommended. It can be deferred. That means deferred means they have to be under monitoring. Persons without evidence of cirrhosis and persistently normal ALT levels and low level of HBV replication. That means they are positive, but they don't have cirrhosis features and their enzymes are normal and the DNA is less than 2000. So they have to be closely monitored. Again, continuing monitoring is necessary in all these patients, which I already mentioned. And when they go to the other stage, maybe they have to be considered for antiviral treatment. Before we go to the medications, there can be some extrahepatic manifestations of both B and C. So one is your B serum sickness like syndrome, polyarteritis nodosa, and glomerular disease. So whenever you see a glomerular nephritis and other things, normally we screen for hepatitis B also. As far as C is concerned, it causes much more extrahepatic like glomerular nephritis, cryoglobulinemia, thyroiditis, maybe cross-reacting antibodies are there, Sjogren's, insulin resistance, type 2 diabetes, some skin manifestations. And very interesting thing is they can develop cognitive dysfunctions, fatigue, and depressions. So maybe when somebody is unexplained fatigue, depression, and dysfunction, cognitive. Maybe we have to screen for C also. Okay, now coming to the antiviral drugs. Again, as I mentioned, it is available under the national program and provided free of cost. So we have got 4 important combinations. One is a tenofovir TDF, they call it disproxyl fumarate. We have to give 300 milligrams once daily. Next we have is the entecavir, that is compensated liver disease, and lamivudine nave. For them, 0.5 milligrams once daily. And next that is for entecavir, but higher dose. Those who have decomposed liver disease, 1 milligram once daily. And we have tenofovir alphenamide fumarate. First one is disoproxyl fumarate. This is alphenamide fumarate. These are the 4 drugs. Friends, just I want to share that we already know about our AIDS program. We have ART, antiretrovirals, and other things. Today, the viral hepatitis program is also combined with these, what should I say, organizations. And these people take care of administering these drugs also in their practice, because one of the deadly combination is hepatitis B virus and HIV also. The next interesting thing is, luckily, most of the patients, even though they harbor the viral hepatitis, the natural remission or natural clearance is there, and they may harbor the virus, but they may not manifest the disease. But as I said, if the indications are there to start antiviral, most of them, they may require lifelong treatment. And there are very few indications where you can think of stopping the treatment. Otherwise, most of them, they can have to be taking lifelong all these medicines. Again, for the pediatric also, they are mentioning about the doses based on the body weight. Then this is another important slides to know, because even though the government is starting the treatment and they are able to get the drugs, or as a practitioner, you are starting the medications for these patients, most important is follow-up. I think for any public health problem like dengue or your COVID, or for this matter, viral hepatitis, the role of family physician is very, very important, because follow-up is mostly done by you in your practice. So this checklist clearly tells at the end of 3 months, what are the tests should be repeated, at the end of 6 months, at the end of 9 months, at the end of 1 year, how this monitoring should be done is very clearly mentioned. Then before we switch to hepatitis C, we see some differential diagnosis. So even though viral hepatitis is an important public health problem, still, as I mentioned earlier, alcohol is still the most common toxin-induced liver disease in our thing. In fact, for that also, we are having a program of non-alcoholic steatohepatitis. All those metabolic syndromes are coming up for non-infectious liver disorders. Of course, please don't forget drug-induced hepatitis is one of the common presentation in our practice. So whenever a patient comes with jaundice, always rule out any drug-induced jaundice, and we have long list of drugs. It can be a directly hepatotoxic drugs are there, or it could be idiosyncratic reactions to the medication. So these are the 2 mechanisms by which drugs can cause jaundice on hepatitis. Acute, again, congestive cardiac, acute liver congestion can mimic like a viral hepatitis. Metabolics like Wilson's, other viruses, because the topic is on viral hepatitis. Unless prove otherwise, we know it's only the hepatitis virus, but there are cytomegalovirus, herpes simplex, Coxsackie, even measles, mumps can cause virus-induced hepatitis. Toxoplasmosis, again, as well as bacterial, we're talking about rain-induced and weather-related. Still, our leptospirosis is very common in our practice. Brucella and tuberculosis. Again, of late, when all other lesions or other etiologies are ruled out, there is a spectrum called autoimmune hepatitis. Again, it has to be ruled out. By ruling out other things, then you can suspect autoimmune. And very, very important component is your pregnancy. Again, pregnancy and jaundice is another interesting topic, but we should think of other jaundice like acute fatty liver, cholestasis of pregnancies, and ischemic liver injury. These are the other differential diagnoses which should be always kept in mind when you are handling a viral hepatitis. Again, don't forget that can be more than one problem, one insult to the liver also. Again, complications, it cause relapsing, cholestatic, fulminant. Again, fulminant hepatitis we have to plan for a liver transplant like that. Other very rare complications like pancreatitis, myocarditis, atypical pneumonia, in fact, one of the investigation for aplastic anemia is hepatitis B have to be ruled out. Transverse myelitis, neuropathies, and autoimmune hepatitis. So I will not go into this flow chart. We will share it later in the group. Again, our infectious disease program is doing very well, and we once in 2 weeks viral hepatitis to our program also to discuss in detail later also. Again, now I come to the fourth case where we are mentioning about mother coming with IAN, mother coming with about that. So one is, as I said, we have to do all these parameters like your enzyme studies, viral load studies, and fibroscans. All those things should be done. And generally, they avoid antivirals in the first trimesters. But if indications are there, maybe second trimesters or in the third trimesters, they can start. But otherwise, if there's no liver dysfunctions, mother is just carries a surface antigen. Otherwise, other liver parameters are normal, and liver other functions are also normal. We can wait and watch. No, it's not a contraindication for termination of pregnancy. You can allow for a normal delivery, no indication for cesarean section. Following birth, that is very, very important. Ensure that hepatitis B vaccine is given to the baby, and also hepatitis immunoglobulin is given to the children or babies born to the hepatitis S positive. This is very, very important because I already mentioned perinatal transmission contribute to 90% of hepatitis B transmission. Again, the mother has to be counseled for taking the virals if needed, and mother also, the baby also has to be screened for follow-up. Again, there are 4 doses of vaccine to be given to the baby. 0 dose is given immediately, and we have to give it later at 3 doses later. Along with now today we are giving pentavalent vaccines, which includes hepatitis B. Then, of course, this is a program that I already mentioned. 6, 10, and 14 weeks dose 10 grams is given. Micrograms. It's not gram. Micrograms is given. And also follow-up of all the babies born is important. And these are the various follow-up parameters of monitoring I already mentioned. Again, you should know when to refer to here. So especially they are mentioning about people who are on repeated blood transfusions for thalassemia, chemotherapy, hemoglobinopathies. All these people better that they are because they are likely to develop much more complications. So refer to your IL center. So finally, we'll come to the other important culprit of viral hepatitis is your C. As I said, this is one virus which we can offer a cure. Virus which can cause so much of complications can be given a cure by taking medications for 12 weeks. We'll come to that. Again, the same guidelines, more or less the same guidelines what we saw for the hepatitis B is being replicated here, but the medications are for example, normally we do an anti-HCV because HCV RNA viral load is very expensive. So the screening test for hepatitis C is only anti-HCV. So if it is positive, then you can go for a quantitative assay. Then you do the baseline investigation. I already mentioned about APRI and other things. This is how the flow chart goes. So what drugs we are going to see? There are 3 important drugs. We'll see that. Sofosbuvir and daclizumab are there. Then ribavirin can also be used. We'll see the drugs. So this is again the flow chart of the thing. Okay, these are the 4 important drugs that we normally recommend. One is sofosbuvir 400 milligrams once a day, or daclizumab 60 milligrams once a day, or based on these 2 combinations we can give. And again, ribavirin can also be tried. Again, all these drugs are available under the national program. So these are the various regimes based on the category of the patients. Without cirrhosis, we use sofosbuvir and daclizumab. Patients with cirrhosis, we have instead of daclizumab, we use the velpatasvir. Again, when the patient is in critical phase, hepatic liver failure, cirrhosis, and decompensated, maybe we can think of adding the ribavirin to the regimes. Again, as I said, all these regimes are based on the consensus formulated by the Government of India, Ministry of Health and Family Welfare. So whenever an important disease of national importance is there, again, I humbly request all our family physicians to follow this protocol so that there is uniformity. And again, as I said, there's very clear-cut guidelines are there based on individual parameters, how to decide to start or when to wait and watch. So again, monitoring and what are the things that we need to monitor. As I said, the whole treatment, we can get it done in 12 weeks. So these are the various parameters apart from your liver parameters, your renal parameters, especially for the toxicity of the medications, what we use. Again, we should know when to refer the patient to a higher centers later. So again, this is a final chart that I wanted to tell that summarizes everything on hepatitis B, which is much more common in our place. And I already mentioned about the parameters. So before I conclude, please check for hepatitis S antigen, liver enzymes, viral load, and two important scores of comparing the enzymes with the platelets and FB4 scores. These are viral loads. Again, this is a flow chart for the hepatitis C with AIDS control program. As I said, hepatitis B, C, and HIV, they go hand in hand. So now the program is also combined with this ICTC and other ART centers. So friends, to conclude, again, as I said, it's a major public health problem and it is creating a silent epidemic across India and across the globe. And while hepatitis A and B are often caused by sporadic or outbreaks, it's a self-limiting, not much treatment needed. B and C needs monitoring. That's very, very important. Again, they can be self-limiting, but we should know when to start the antiviral, especially for C. Once it is positive, then definitely you have to start them on antivirals. For hepatitis B, there are indications of monitoring and we have to know when to start the treatment. And counseling, that's very, very important because many of them, the drug compliance and adherence is very critical in these kind of patients because they need long-term management. So they have to be followed up, not only for the viral multiplication, as well as for the side effects of the medications. Again, as I said, July 28th is being observed as a World Hepatitis Day. Again, we have to create awareness through social media and through press media, and we can have IMA meetings, creating awareness in the community as well as among the doctors. And I am sure together we can win the war against hepatitis. Thank you for your patience listening. Thank you.
Thank you, sir. Thank you for the elaborate discussion on hepatitis and the importance of the World Hepatitis Day. And if you can stop share, sir, yeah, can. So one question we'll just take, sir, before Dr. Suresh joins. How often we should take booster dose?
I think we have to go by the antibody titer because the immune response to the individual, normally we advocate 3 doses, 0 dose plus 3 doses we advocate. And especially doctors, those who are at high risk profession like doctors and lab technicians, I think the guideline says you have to check your antibody titer and take the boosters. Maybe once in 5 years, we can check the antibody
titers. Okay, sir. Yeah. Thank you, sir, for the discussions. Now we will go to the next topic. So we have Dr. Suresh Kumar, ID Specialist, Apollo Hospitals. He is one of the core team of our ID course. Dr. Suresh Kumar, sir, can you unmute yourself and check your mic is available?
Sir, can you allow me, because I joined through my system, but right now it's not allowing me there. I joined as Dr. Suresh Kumar ID. Otherwise, you start
Okay,
sharing
sir.
my slides. I'll present through the thing.
I
saw my
I can
system is
share,
ready.
sir.
My system is ready, but you can allow me so that I can present also.
Now you
I joined
know,
the
sir, you can do it now.
Dr. Suresh Kumar ID is mentioned there.
Yeah, share, sir.
One second, sir. I put the username and password. 1 second, just.
Can you share
I
now?
try my system.
Yeah.
If you allow me, I'll just join that.
No problem, sir. Yeah. So till Dr. Suresh Kumar joins, sir is one of the ID specialists who takes
Dr.
about
Mohan
specific
Kumar.
on the
Mohan Kumar.
problem-based infection.
Mohan.
Sir?
Yeah, just
Sir,
because
join,
somebody was asking about antibody and other things. No, another important point we should know is, suppose if somebody is vaccinated for hepatitis B and he develops antibody, means he will develop antibody only against hepatitis S antigen, surface antigen. So he will not develop antibody for E or core antigen. So if a patient has only natural infection, he will develop antibodies against all the three. So that is one way of knowing whether somebody is having antibody against S, it's because of vaccine or it is because of natural infection.
Okay, sir. Thank you, sir. Admin, can you make Suresh Kumar ID as a
co-host? You just start sharing my slides, sir.
Yeah. Thank you, sir. Can you, sir?
I'm not able to say. NA only is there. Right.
Yeah, I think you are not, sir. Admin can make Dr. Suresh Kumar ID as co-host.
Okay, sir. You start sharing, sir, because it's been my audio has some issues. You better join. Okay, you start sharing, sir. I can present through you.
I will share your slides. Yes. Sure, I'm doing it now. Share. Yeah. Over.
Yeah. Yeah. Thank you, sir. I sincerely thank the IMA CGP wing for giving this wonderful opportunity. And I thank my moderator, Dr. Mohan sir, for coordinating, and my other speakers also is coordinating there. So today I'm going to discuss about the typhoid. Already my previous speaker spoke about influenza, hepatitis, how to approach. So I need to talk about today typhoid. So since some technical issues in joining with my system, there I asked Dr. Mohan sir to share my slides. I'm discussing it there. Next slide, sir. So this is my disclosures. We are ID doctors and we tackle a lot of issues what we are facing in our real practices. Otherwise, our money is not a great earning, but we solve a lot of problems we are solving. So that is our disclosure area right now. Next slide, please. Next slide, sir. Yeah. So I begin with the case here because we are fag end of our program there. So I don't want to bore with theory. This is a 28-year-old male. Like, I'm going to stick to this case throughout my presentations here. This is a 28-year-old male working in Chennai with a fever of 8 days duration. Basically, he got diarrhea of 4 days durations. Similar febrile illness twice in the last 2 months. Travel, he treated with some antibiotics of 5 days. Started with this time levofloxacin, but still fever is going on. Is native of Andhra Pradesh. On examination, is febrile and spleen is positive. Spleen is palpable. So this is a case presentation. 28-year-old male from Andhra Pradesh, working in Chennai, and is having fever of 8 days durations, diarrhea of 4 days durations. On examinations, febrile and spleen is palpable. What will you do now? People are putting their name to get the credits, but I want people to answer the questions, whatever polling questions we are putting it right now, so that your credit points will be validated now. Almost nearly 1,000 odd people are sitting now. So what will you do? People say, I want to take a detailed history. Whatever history I am provided is not sufficient for you. Plus, you need to do a detailed physical examinations, history plus examinations, or I need to do some CBC test in addition to history and physicals, I want to start some antibiotic apart from the 2 or apart from the 3, or just wait for ask for Vidal test. Why you want to complicate it? If you ask Vidal, the Vidal is going to give the answer for you. I just want the participants, almost 1,000 odd people, but only few people answered so far. They say 4 or they want to see 4, but nobody wanted to do number 6 in the thing. People want to do either 4 or 3. That's a good possibility there. Next slide, please, sir. So next slide, please. So this is my objective today. We are basically looking at it when you come across this type of infections, whether it's influenza or typhoid or hepatitis, what we need to know. First thing, we need to know what we are dealing with it. For example, if we are dealing with a typhoid fever, we need to know what you mean by typhoid fever. Second thing, why we need to learn this one, because something rare, something exotic you're not going to see, it's not going to help your practice. How it is going to help my practice. The third thing, when to suspect. What are all the things I need to ask? What tests I need to do? How to confirm the diagnosis and how to start the medication. This is my plan here now. Next slide, please, sir. So same again. Now this question is same. The clinical case history is same. So how many say that this patient has got typhoid? Based upon the history, based upon the physical examinations I provided to you, can you say this person has got typhoid? Please go ahead and vote. This is choices are different, but the question remains same. What do you think? Previously asked, what will you do? People say history examinations, but now despite taking history, despite taking examination, people say maybe. It's not only the diagnosis, because people listen to the talk of influenza, listen to the talk of hepatitis, they say maybe this is not only typhoid, despite knowing this talk is about typhoid. People don't want to put the money on typhoid. Yes, I need to want the viral test also. Finally, somebody wanted to do some just to know what is going on. That's a good thing there. Next slide, please. Yeah. So before that, I told earlier, when you deal with some problem, you need to know what is the problem. Unless you know the problem, it's a bit difficult for you to do it. What is enteric fever? People always confuse enteric and typhoid. Enteric is a broad one. Enteric is a broad one. It includes both typhoid and paratyphoid for you. It includes both typhoid and paratyphoid for you. But in typhoid, 1 second, sir. My slides are stopped. Start sharing that. Sir. Thank you.
Let me know, Suresh, sir, once you are ready. Yes. Can you make it slideshow, sir?
No, sure, sir. Thank you. Thank you, sir. So
can you make it slideshow?
Yes, I'll do it, sir.
Can you make it as?
I'll do it.
Yeah, sure.
Yeah. Thank you, sir. Thanks for bearing with me.
Yeah,
sure.
Perfect.
Yeah. So when we deal the patients, what is enteric fever? We need to know. Enteric is a broad one. It includes both typhoid and paratyphoid. Apart from the enteric, one more thing is called Salmonella typhimurium that causes diarrhea alone. So these things we need to keep in mind. So typhoid is basically caused by systemic illness. It's an acute febrile illness caused by the bacteria called Salmonella. Paratyphoid is caused by paratyphoid A, B, C, but C is less likely. More paratyphoid A is common, particularly in Indian scenario. Paratyphoid A is coming up nowadays. Enteric is both waterborne as well as foodborne diseases. Vaccines available that only prevent typhoid. So for paratyphoid, there is no vaccines are available right now to me. So this is you'll keep in mind. So if you see the terminology, there are a couple of terminologies. Enteric fever means acute febrile illness due to Salmonella species, particularly the Salmonella typhi. But what do you mean by carrier? Convalescent carrier means people who recover from typhoid. Not everybody. Out of 100 people, if they got typhoid, 10% of the people can go for a carrier for short period of time after recovering from the illness. But chronic carrier, even more less, particularly they can go for 1 to 4% of the populations. They keep on shedding the viruses in the stool for more than 1 year also. People know the famous lady called Typhoid Mary. She's basically cook. She's not a healthcare worker. She's a cook by occupations, and she started spreading the diseases almost to 100 odd people there, and almost she killed like a 12 to 13 people. She was put on isolations, but she keep on escaping from the isolations and kill. She's a classic case of chronic carrier of typhoid there, and she does not follow hand hygiene. I usually put her figure in hand hygiene because she's not followed the hand hygiene, and she transmits the diseases also there. So we need to know certain diseases we can call probable or suspect. For example, we can think when the person has got fever that crosses more than 5 days durations. According to WHO, even 3 days duration is okay. But usual clinical practices, most of the viral fever subside by day 5. So when the fever lasts more than 5 days, that is gradual in onset, and person has got some splenomegaly, and person has got some GI disturbances, we can put the money, particularly the people are young. I show when to suspect typhoid fever in your practice. So I can tell clearly when to suspect typhoid fever. This is called probable or suspect. But small differences. Suspect means any clinicians can have suspect. Probable means when the person, some outbreak is happening, they think about the probable case there. Chronic carrier, I just told 1 to 4% of the patients who suffer from typhoid keep on excreting the typhoid bacilli in the stools, but there is no major symptoms. Confirmed case means we need to prove by only blood culture positive, not the Vidal positive is not equal to typhoid. Only blood culture proven typhoid is positive to consider as a confirmed case of typhoid. So know the cases, that's most important thing. Suspect means any person more than 5 days of fever, person has got GI disturbances in the form of diarrhea or constipation, not expectedly diarrhea. The person might have constipation also, and the fever is a gradual onset, step up and step down. I'll come back and explain during my physical examination part of it. So these things we keep and remember in mind. And carrier means people excreting but without any major symptoms, but they can transmit the disease to other people. So know your problem. First step in infectious diseases, know your problem. Unless you know the problem, what your definitions is a bit difficult to tackle it off. Then why this talk? We need to know why I need to learn about typhoid in one of the CGP meetings there. This is common problem. This is not a rare problem. If you see worldwide, this is 14.3 million cases has been happening. Not like expected the COVID level, but definitely the numbers are significant. India, Pakistan, Bangladesh constitute 85% of the cases of typhoid to the world. And South Asia is most important part of a typhoid is more common. If you see the map, I shown two maps. One is the number of cases reported. Second thing is the number of death also. So it's not a mild disease. Particularly if the people are treated, the chances of death is very low. People who are not put on appropriate antibiotic, the death is more. And complications are also more. But more important, of late the resistance is emerging. That's more concerning to us. And third thing, this is an easily preventable disease. This is easily preventable disease. Keep in mind, it's not a rare disease. It's easily preventable disease too. For example, if you see the resistance pattern, one more reasons why you want to join the IMA-CGP. This is a very important thing. We provide update to you. Still, people are using typhoid means people are using ciprofloxacin, ofloxacin. If you see the resistance pattern in 1980s, yes, ciprofloxacin, ofloxacin is a drug of choice. But what happened in 1990s and 2000? What resistance mechanism is common in typhoid is called naldixic acid resistant typhoid. Previously, MDR typhoid in 1980. That is why ciprofloxacin, fluoroquinolone they invented. But what happened in 1990-2000? Once you start using your fluoroquinolone, the bacteria start developing resistance. What happened now? All drugs, for example, cotrimoxazole is working, ampicillin will work, amoxicillin will work for typhoid. What will not work? Your Cipro, ofloxacin will not work for typhoid. That's a problem here now because the resistance is now. But what happened to your neighboring country, Pakistan? Even worse, people start using ceftriaxone and cefixime. That is also resistance in the neighboring country. That is a real worrisome problem. Why? So much of abuse of antibiotics, so much of reasons they're using antibiotic. I'll come back and explain a little later part of it. Why typhoid abuse has caused this type of XDR typhoid, ESBL typhoid. This is big problem. E. coli, Klebsiella, I understood. But for typhoid, we are using meropenem. That's a problem. So if you see, this is the algorithm people are creating now. Whether the person got XDR typhoid. XDR means resistant to common antibiotic like cephalosporins. Third generation cephalosporin, azithromycin resistance is there. People need to use last resort of antibiotic like meropenem. Even sometimes meropenem also start developing resistance or peak is going up. The MIC is going up. So this is the reasons we need to know typhoid in depth. Otherwise, it's a bit difficult for you. That's why the session is arranged for you. Then coming back to the same case, the person now, what is the risk of getting typhoid? I know the person is The person has got 8 days fever. So probable typhoid, according to the diagnosis, probable or suspect to you. The person has got fever, the person has got diarrhea, the symptom is lasting more than 8 days durations. What made you to think, what is the risk of his getting typhoid? Any thought process? Whether he's working in Chennai, I want almost 900 hard people are there. Please go ahead so I can see your responses also now. So without any issue, what do you think? Patients has got fever, diarrhea. When you give all of the above, people always tempting. People living in Chennai is a reason. I do not know who is abusing Chennai. I put it, but people are telling it. Living in Chennai is a reason for it. Or native of Andhra Pradesh, spicy food is causing some problem. We do not know. So people are worried about it. They're fine. So I just want to have fun. No other intention there. Just put Chennai there. So who gets typhoid? When you think about it, children are vulnerable. This graph is unfortunately the Lancet Infectious Disease references I quote. It clearly mentions people less than 40 years, particularly less than 15 years, the risk is very high. Why? People are eating unhygienic or people not maintain hygiene properly. Particularly in the schools, people start drinking some school water. The water is not clean. Second thing, the food, particularly the street foods, people start liking to street food. Particularly now the famous food is pani puri there. People start eating whichever food is not cooked, not boiled, not peeled by you, risk of getting infection is very high. I've shown a couple of pictures in this American Tropical Journal Medicine. People eating dairy items, particularly the frequency is more than 12. Not one time eating, the chances are a bit low unless the inoculum is more. Similarly, ice creams, people are eating it, and fruits and juices, particularly fresh juices, whichever thing is packed is fine. Fresh juices risk is very high. Shellfish and fish, egg not boiled properly, vegetables which is not cleaned properly. So for me, whichever food is not cooked, not boiled, not peeled by you, the risk of getting typhoid is very high. Particularly the curd rice, chutney, these are all not safe. Whichever food is cooked, for example, sambar is safe for me. So who gets typhoid? People living in endemic region. Yes, I have shown the graph. India is endemic to typhoid. Yes. Young people, because sometime if you grow above the age of 40, because of the recurrent exposure, you might develop some immunity that can prevent the complications. But half late, last 1 year, we have seen little higher age group also. When you see higher age group, chances of typhimurium is very high. Eating outside food, people are eating once in a while, chances of picking is very unlikely. But people eating most of the time and outside food from home, chances of picking typhoid is very high in the corner. So what will happen to typhoid? Once you start eating the food, it crosses your stomach, it reaches your intestine, it attracts the macrophages, then it enters the lymphocytes, payers, pages, it multiply and causes inflammation there. Either causes fever and diarrhea or systemically it can invade and go and settle in the gallbladder. So this is a pathogenesis, a pathophysiology for you. So coming back to you, why you suspected typhoid here? So that's the case I'm asking that this person, you know, why you are suspecting the typhoid? Because I know the person is endemic region, the person is in young, less than 40 years, and the person is eating outside home food. Yes, this is alone a suspicion for it, or what the clinical parameters. Now we need to diagnose the persons, not only the epidemiology. Yes, I know epidemiology plays a big role. Apart from the epidemiology, as a clinicians, what are all the clues you are getting it here now? People say 8-day fever is a clue to me. And people say 8-day fever, diarrhea, and splenomegaly is a clue to me there. So based upon the thing, but nobody say I want more investigations and vital results. Nobody right now is asking for the confirmation. That's a good news there. Okay. So this is the symptoms. If you see the pediatric age group and adult populations, usually the fever is a high-grade fever. But what is a classic hallmark of the fever? This is a gradual onset fever, not like viral fevers. Sudden onset of fever. My previous speaker clearly told influenza comes as a sudden bout of fever. This is a gradual onset. People cannot say at what time the fever started. If viral fever, people can point out this is the time I got the fever, 3 p.m. yesterday. But here in typhoid, they can't pinpoint it. And the fever is also first 2-3 days, maybe 99, 100. But afterwards, third day, fourth day, it starts picking up to 101, 102. That is called step up, climbing the steps. And coming down also, whatever treatment you are putting it won't come down drastically like pneumonia. If you start treating a pneumonia, the fever will settle down. That's called fever coming down by lysis. But here the fever is going down very slowly. That's called step down fever. Gradually step up and step down. This is called the gradual onset. I'll show the picture a couple of minutes later. And apart from the fever and GI disturbances, you might have also cough, you might have also other things. But common clinical examinations, hepatomegaly, splenomegaly is more common compared to other things. Abdominal tenderness more common in pediatric age group. So if you see the GI symptoms is predominant, whether pediatric or adult, GI symptoms is main. Similarly, hepatomegaly, splenomegaly. People will keep on asking about some things like relative bradycardia. When the temperature shoots up, the heart rate also shoots up. But in typhoid, the heart rate is not going up. Similarly, people talking about rose spots. Rose spots is specific, but unfortunately, the sensitivity is not great. Hardly 5 to 10%. People like India, dark color, it's very difficult to appreciate the rose spots. So you can't expect coated tongue is possible, but coated tongues is not specific. These are all the futures we need to think about it. So this is a pattern I'm talking about it. Typhoid means step up, and the fever gradually builds up and gradually goes down. So the fever usually lasts more than 5 to 7 days. Whatever antibiotic, despite giving a good antibiotic, you don't expect fever to subside on day 3, day 4. It will take more than 5 days. Sometimes if it is salmonella typhi, take more than 6 to 7 days also. We need to wait and watch so that fever will take some time to settle down. No hurry to go down immediately. So if you see week wise what is happening, week 1 and week 2 of fever, mostly the intensity of fever is very high. Started building up in the week 2, it reaches a peak, then it slowly starts subsiding. Similarly, the GI symptoms also can come in the week 2 also. Other symptoms are a bit low, like cough, the weakness and tiredness is a bit low. Otherwise, the patient has got this type of symptoms is going for a long time. Then common signs, if you see, hepatomegaly, splenomegaly, rose spots is present fine, but we have not seen any rose spots cases. Relative bradycardia, again, unlikely because most of the time we are not focusing on it and think coated tongue is more important, but mostly splenomegaly has got a characteristic features. So, but what happened in tropical country? We can't say the person has got more than 7 days of fever, is a young individual, and the person is eating outside food. Yes, agreed. And the person has got splenomegaly, and the person's fever is gradually built up. Can you make the diagnosis? If you see the differential diagnosis, malaria, leptospirosis, rickettsial infections like typhus, most of the things has got similar symptoms. It's a bit difficult to differentiate from one from another, but when a person has got more than 7 days, the chances of dengue, the chances of influenza can go down. The person receiving some appropriate antibiotic like levofloxacin or something there, it will work for your leptospirosis also. Not for scrub typhus, may not there, but it will work for leptospirosis too. So we need to think about the drug history, what medication the person is taking. Despite taking the medication, the person is not improving. Keep in mind. So that's why physical examination, this is a beautiful chart of BMJ, but see the problem with typhoid. All other things, the blue circle indicate non-severe disease. The triangle indicates severe disease. For example, the person has got malaria. The blue thing, what happened? The person has got rash and lymphadenopathy. It rules out the disease. But on the other hand, ruling features means the person has got high temperature, splenomegaly, intermittent fever. The chances are a bit high. So we need to know. But if you see the typhoid fever, what happened to the typhoid? There is no blue in non-severe disease. There is no characteristic feature to say this person has got typhoid. Similarly, even in severe diseases, whatever features I mentioned, it is very uncommon features, not a common features. So clinically, to make a diagnosis of typhoid, we need to consider all the parameters. Young individual, eating outside food, fever lasting more than 7 days, that too gradual fever, step up and step down fevers, along with coated tongue, along with splenomegaly. If you are lucky, relative bradycardia, rose spots, yes. Otherwise, it's a bit difficult for you. This is called the rose spots. Very difficult in a fair person, yes, but complexions of India is very difficult to differentiate. Usually present in the chest, present in the abdomen, very rarely is present in the limb. What it is, it's an erythematous macule or papule, just touches, it blanches. That's more important for you, otherwise it won't do anything. So this is a characteristic features. But instead of looking at a rose spots, what we need to do, seeing the red spots is more important for me. Red spots means the person has got red flag signs. The person has got altered mental status. Respiratory rate more than 22. The person's systolic BP is low. These are all called vital parameters. When the vital parameters are a bit low, the chances of sick, the person need hospitalization. The person need close admissions. Instead of looking for a rose spot sign, look for the red flag sign. That is more important for you to figure out when to admit the patients, when to start IV antibiotic. That is practical instead of searching for a rose. That's why we say in children, these are all the common thing. When to suspect severe disease, when to hospitalize, when to give IV antibiotic. So coming back to this case now, again the persons are given some lab investigations. Unfortunately, the Vidal test is negative. So people looking at it, classic presentations of typhoid fever. Patients staying away from the home, eating all sorts of Chennai food, and the person's fever is also more than 8 days, and the person has got splenomegaly. But if you do the investigations of the Vidal on day 8 of the fever, not day 5 of the fever, day 8 of the fever, Vidal is negative, but leptospirosis is positive. So what do you say now? How many say, instead of putting your name for your credit, please answer and get the credit there. So what do you think the person has got? typhoid or non-typhoid? Yes, no, maybe. People say yes, despite Vidal is negative, they put the money on typhoid. But leptospiro IgM is positive. It is not a mixed infection or not a single infections. People say no. Only out of 900 odd people on the line, only few people are answering it there. Vidal is not helpful. Okay, but still people are loving to do Vidal test for patients with the typhoid. So always be interactive, keep on interacting throughout the presentation there. Okay, good. So we need to know our enemy. In infectious diseases, first we need to know what syndrome I'm dealing with it, what disease I'm dealing with it. Second thing, who is going to get the disease. Third thing, how to know the confirmed diagnosis. That's most important. For that, we need to know this is a typhoid bacteria with lot of flagellus and fimbriae are present. It has got some surface antigen. It's called VA antigen. Usually, Vidal test relies on two. One is called somatic antigen. Other is called flagellar antigen. So this belongs to gram-negative bacilli. It is similar to E. coli and Klebsiella. It is a gram-negative bacilli. It secretes proteins also. This is a basic structure. Then we need to know what test to do, what not test to do. The gold standard is a blood cultures, but most of the GP say the blood culture will take 5 to 7 days. Of late, most of the laboratory, they change over to automatic system. What is the advantage of automatic system? If you put the bottle in the automatic system, we know daily we can check whether growth is happening or not. We need not wait for 5 to 7 days. I did my undergraduations and post-graduations in Stanley. During my Stanley time, I never picked up one blood culture proven typhoid. Why? Because I sent 2 ml of blood, 3 ml of blood. Usually 2 ml of blood, 3 ml of blood. For blood cultures, it is not going to pick it up. If you want to make a diagnosis of typhoid, minimum 15 to 20 ml of blood I need to send for cultures. That means one set. One set means one bottle of aerobic, one bottle of anaerobic. Each bottle, if you put minimum 7 to 8 ml of blood, the yield is much higher. We do in corporate hospitals, we do 2 sets of culture. That means I send 4 bottles. That means each bottle contains 7 to 8 means minimum 25 to 30 ml of blood I'm putting it. That is why I'm daily seeing blood culture positive typhoid. But during my undergraduations and post-graduations, I send only 2 ml of the blood. Volume plays very important. Even if the person taking antibiotic, if I send a sufficient volume, the culture may turn around. And nowadays we are using automatic system. We know the culture reports daily basis. Don't wait for 5 days. 5 days is the final time. But you can call the lab any growth happened or not. That is most important. Serological tests, I'll come back in a minute and explain why the viral test and why other test is not reliable. And I'll tell for the GPs what to do also in a way, trick also. This is a reason we are against serological tests. For example, viral or person has got typhoid.IgM. Any test has got sensitivity, specificity, positive predictive value, negative predictive value. Sensitivity means able to identify the disease in 100% of the people. What is the sensitivity? Specificity means if it is positive, whether it's a true positive or not. Positive predictive value means what is the likelihood of a disease if the test is positive. What is negative predictive value? When the test is negative, it tries to rule out the disease. But if you see for the viral test, all around 50% or 54%. What it indicates, we need to toss a coin. When a head comes, the person has got typhoid. When the person tail comes, the person is not having typhoid. We can't rule it out. Negative predictive value also same. Positive predictive value also same. Sensitivity, specificity, everything is around 50%. When the test has got 90% specificity or the sensitivity is really good, yes, or negative predictive value, at least if the test is negative, I can rule out the disease. If the test has got 95% or something, yes, good. But unfortunately, the viral test lacks everything. That is why we are not relying on a viral. And viral is a test of historical interest for me. Why? Because if you do the test yearly, for example, on day 2, day 3, it is negative. Sometimes if you start taking the antibiotic, there is no sufficient antigen load to find out viral is positive. Sometimes what is a false positive? False negatives are there. False positive, even dengue can cause false positive. Even your enterobacteria, E. coli, Klebsiella can cause false positive viral. Suppose if you had typhoid once, how long the antibody is going to remain, we do not know. What is a significant titer? There is no good studies. 1 in 160, 1 in 320, 1 in 640, we do not know. So single viral has got very, very limited role. Very difficult to say. It has got no sensitivity, no negative predictive value. I can't use viral to make a diagnosis. What I need to do, I need to do 2 viral. For example, on day 5 to day 7, 1 viral. Day 10 to day 14, second viral. If 4-fold rise has happened between first viral to second viral, I can say the person has got typhoid. So how much time the patient need to wait? 10 to 12 days for making a diagnosis of typhoid. And the fever is going for 7 to 8 days even after starting antibiotic. How many patients is going to wait for you to say I need 2 virals to do? You can say one Vidal, I can do it on day 1 or day 0, and another Vidal at day 7 to see the rising titer. Minimum 7 days the patient need to wait. That is why Vidal is a test of historical interest. We don't rely on Vidal. I am not telling Vidal is not reliable. This is WHO. Single Vidal has got no diagnostic significance in endemic regions. For example, US and everything, where other Salmonella species. In India, there are so many Salmonella species. It's called non-typhoidal Salmonella, but all can produce antibody. That's the problem. Not only E. coli, other Salmonella like Salmonella typhimurium, Salmonella enteritis, they can produce antibody. That is a problem, so we can't rely on it. Then people say Typhoid dot. Typhoid dot is similar to antigen-based test. What is the problem with the Typhoid dot? It has got reasonable negative predictive value, but we need to wait for 5 days to do the test. On the day 5, if you do Typhoid dot IgM, if it is turned to be negative, it tries to rule out the infections rather than ruling in the infections. That is good. But what is the drawback? It is only for validated for typhoid. It is not for paratyphoid. So Typhoid dot IgM, if you do it on day 5, if it is negative and the clinical picture is not suggestive of typhoid, it rules out typhoid. But if it is positive, maybe typhoid, may not be typhoid. It has got no good, the positive predictive value is not good, but it has got good negative predictive value. That's more important for you. If you see the sensitivity and specificity, even though they claim sensitivity of 100%, but the specificity is not great. Similarly, the positive predictive value is not great, but where it scores negative predictive value. So if you do on day 4, day 5, classic presentations is not present, and if the test is negative, it rules out typhoid, but paratyphoid, it will rule it out. Keep in mind. So blood culture, I told you earlier, it is a gold standard, but even if you send 20 ml of blood, the yield is only 50%, 40 to 60% in best of the lab. Even if you send 40 ml of blood, even without antibiotic, if you send 40 ml of blood, don't expect blood culture will turn positive. Blood culture will turn only 40% to 60% of the time it is positive. Remaining time it will be negative only. Keep in mind. So don't expect blood culture to show positivity all the time. It may be negative almost 40 to 50% of the time. So coming back to this case, then how to click the diagnosis here? Why the person say, people say this is typhoid only, despite knowing leptospira IgM is positive. Why you put, does these patients have typhoid? Now, if you say yes, why the reason? I just want to know why you are saying that patient has got putting the money on typhoid. Despite knowing leptospira IgM is positive, despite knowing Vidal is negative, why you are putting the money? I just want to check the people's response. People still putting the TNMSC number to get the credit rather than reacting to the scenarios there. Please react to the scenario now. So what do you want to do? Can any other bacteria with the biofire adhesions, molecules, and flagella mimic the same? I will answer the questions in the end. Plus, answer this. Why you put the money on typhoid? Despite knowing leptospirosis, people say eosinopenia. Good. Okay. Eosinopenia. Out of 1,000 people, 2 persons want to get the real credit of the TNMSC points. Very good. So 3. Low platelets and TNMSC. Good. So people start answering, we just run. So the trick is eosinopenia. But don't think eosinopenia alone is a marker of typhoid. We go with 4 parameters. 1, the WBC count should be normal. Second thing, the neutrophil count should also be normal. Third thing, the eosinophil count should be 0 or 1%. Then fourth parameter, ESR should be also normal. Along with the clinical picture, the person is a young person eating outside. I shown 28-year-old male, native of Andhra Pradesh, staying in Chennai, eating outside food, GI symptoms, diarrhea is present. In addition, the person has improved with some antibiotic, but again coming back. The person improving means it's not completed the course. So keep on relapsing it. That's most important. And this time levofloxacin has got no typhoid cover. So keep in mind these things before taking decisions. So the person has got eosinopenia, WBC count normal, neutrophil count normal, eosinophil count is 0 or 1. But we have checked so many small labs that are doing this test, but it is not correlating. They did the eosinophil count outside lab 6%, 7%. When I repeated in my lab, it is 0. So the good lab is needed. With a simple CBC, we can able to predict what is the fever is going on. Particularly tropical fevers, we can able to differentiate. Provided good CBC and good LFT and good ESR, we can able to say what is going around. For a clinicians in a rural practice, don't worry about anything. Just know the CBC, but we need to know which lab to send. That's most important thing for you. So the secret is eosinopenia. People ask, is there any evidence? Yes. This is one of the children populations in Kanchi Kamakodi. They evaluated. In children, usually the eosinopenia is not that marker, 70% of the time. But this is an adult populations. I published this paper long time back. In my hospital, the eosinopenia sensitivity is 90%. Vidal sensitivity is 50%. I need to wait for Vidal 7 days. But this test I can do on day 3, day 4. where the eosinopenia is a marker, I can able to make a diagnosis provided the other parameters of history. The person should have young, eating outside food, symptoms of diarrhea, maybe splenomegaly, along with neutrophil count normal, eosinophil count 0, I can think about it. So think these things and put a diagnosis of it. So finally, the blood culture is growing. On day 4, it is growing. Those who are the picture not clear, I shown the picture. Ofloxacin, ciprofloxacin, levofloxacin, which antibiotic you want to start? So I want to see what is your choice. So we have discussed already, but I just want to check. 1 second. Yes, you can get the credit also, but please, yes, people say preferred drug they want to do cefixime or ofloxacin. So we just now discussed except fluoroquinolone, all other things will not work. Even though Cipro here sensitive they put it, but the MIC has been recently revised, so we can't rely on ciprofloxacin, ofloxacin. All floxacin will not work except one gatifloxacin, but that is banned now. So we need to rely on only either all other things, cefixime, cotrimoxazole, azithromycin, ampicillin, and chloramphenicol. So if this is the guidelines 2021, we can see when the person has got, when you do not know the susceptibility results, and the person is in OPD, what antibiotic I can start? Azithromycin is a reasonable choice, provided because azithromycin cover leptospirosis, azithromycin covers scrub typhus, azithromycin cover typhoid. So when you know the person has got some bacterial infection, the fever is lasting more than 5 days, you want to start antibiotic, not for 1 day fever, 2 day fever, 3 day fever. When the person has got fever of more than 5 to 7 days, you are not sure whether it's a lepto, scrub, or typhoid. That point of time, if you want to start an antibiotic, yes, cefixime is a good antibiotic, but will take slow because azithromycin acting intracellularly. Cefixime acts as the cell wall. Salmonella is an intracellular bacteria. Takes some time to kill. If you want to use cefixime, but it only acts against leptospirosis. Cefixime has got no cover against scrub typhus. So that's the other problem. But if you use azithro, it will take care of all 3, but fever should last more than 5 to 7 days. Keep in mind. So if the person is got fully susceptible, but we are not getting fully susceptible, I'll show my data in shortly. So ciprofloxacin is useless because it's susceptible. Maybe in US it's working, but in India it's not working. So multi-drug resistance previously, but it's not common. Nowadays we are getting quinolone resistant typhoid. Either azithromycin, cefixime, or ceftriaxone is a reasonable drug. If you want a carrier, again we can use amoxiclav, or we can use, again provided sensitive, we can use ciprofloxacin. Otherwise cotrimoxazole or amoxicillin glavulinic acid is a good drug. So this is a data we published again 10 years back. In my hospital, even though ciprofloxacin, the sensitivity they put 50 odd %, but real time we need to see the naldexic acid. Naldexic acid is a first generation fluoroquinolone. If the first generation fluoroquinolone is not working, the second generation like Cipro, Oflox, Levoflox will not work. So this resistance in 2013 is 92%. Now we are in 2025, almost the resistance reached 100% for fluoroquinolone. So except fluoroquinolone, use any drug. That's the point I'm making here. So what dose we need to use? If you are using azithromycin, the duration alone 20 mg per kg of the body weight. So you can use up to 1 gram. People want to give 500 milligram BD, that's fine because the diarrhea can happen with 1 gram as a single dose. The durations of treatment with azithromycin is short. 7 days is enough. If you think the person response is poor, you can go up to 10 days. But if you are using a third generation cephalosporin, minimum 10 days, but ideal duration is 14 days. Either ceftriaxone or cefixime. If they keep the person in hospital, use ceftriaxone for 3 days, 4 days. Remaining 10 days, you need to give cefixime. Depends upon total duration is 14 days. People are not using chloramphenicol, but chloramphenicol is useful for other sepsis, but not for typhoid, because typhoid right now we got a lot of options, but in Pakistan the options are very limited. That's the problem. So the algorithm is whether the person has got young people, fever, with patient has got GI disturbances is present or not. If the GI disturbances, splenomegaly, and WBC count normal, neutrophil count is 0, the neutrophil count is normal, eosinophil count is 0, ESR normal, send the blood cultures. If the resistance rate is bit high, don't use fluoroquinolone, try either azithro or cefixime. If the person in hospital, try third generation cephalosporins. Combination therapy has got very limited role. It can cut down the fever at least 1 day earlier. That's only advantage of combination therapy. What complications you are expecting? Usually perforations, but off late we are not seeing perforations. The person is not recognized. The person is not recognized typhoid for a long time. Yes, perforation is possible. Otherwise, perforations and bleeding complications are not there. But what we are seeing is more of HLH, hemophagocytosis. After 7 to 10 days, the body recognizes typhoid. It not only hit the typhoid, but other immune cells like your WBC, your hemoglobin. So hemophagocytes can happen. That's possible there. And we are seeing not intestinal perforations, hemophagocytosis we are seeing now. So when to suspect severe typhoid? When the person is not able to take anything by mouth, and the person has got severe diarrhea, the person has got dehydrated, his vital parameters were not stable, we need to consider the person need to be in hospital. What is the death rate? 1 to 4% in a treated patients, particularly in children is more common. In adult populations, untreated patients, the mortality is 10 to 20%. Keep in mind, the intestinal perforations are a bit low. This is a complications I've seen. So coming back, now mother is worried. The son is keep on getting fever, that too typhoid fever, recovering, getting. So mother is worried about it. So she's asking about my son turned to be a typhoid naga, Mary or typhoid naga, Thomas or something is asking about it, what to do there. What will you do now? Shift to Andhra so that the mother's food will be safe. Just go ahead and respond there. So do the stool culture to find out the carrier state. Most of the time we don't do the stool cultures to check. To give a long-term suppressive antibiotic, or consider this person has got a carrier, remove the gallbladder, or consider some vaccines to prevent it. Already he got typhoid. Even after vaccines is going to help him, the person already got typhoid. So 3 times, 4 times, the natural immunity is get good compared to the artificial immunity. What thinking about the vaccines? So people answered this one. Okay, good. So how to prevent? Basically, this is a foodborne disease or waterborne disease. So we need to take care of our food and water. That's most important thing. You need to try to avoid outside food, one, or if you want to eat outside food, whichever food is cooked, boiled, peeled by him, you need to eat. Because we can't shift always outside home food there. Sometimes we need to eat outside food. When you're eating outside food like chutney or curd rice or pani puri or fresh juices, always think typhoid is going to come 2 weeks down the line or 3 weeks down the line. So we need to take care of the food. Similarly, water also, good quality water we need to eat, and we need to wash our hands. And people who are preparing the food, particularly for hospital, you are running a canteen in the hospitals, take care of your hygiene of your food handlers. Most of the hospitals, they're not taking care of the food handlers. That is why hospital outbreak can happen. If you're running a small nursing home, small hospitals where you are providing your food, take care of the health of your handlers, food handlers. Otherwise, you are going to suffer. That's most important thing. How about the vaccinations? For example, almost all Western country, they are telling if you are visiting India, we need to take typhoid vaccinations because food in India is not safe. The water in India is not safe. That's why they're recommending typhoid vaccinations for most of the country, whether it's Australia, Canada, or France, most of the country, for the citizens, they're recommending if you're going to India, please take the vaccinations. What vaccinations we need to take? There are 2 vaccines, but one is not available right now. One is called the oral typhoid vaccines. Usually above the age of like 6 years is usually recommended, but right now it's not available. We need to give multiple doses. This is oral vaccines, live attenuated vaccines. But what is available? There are 2 vaccines available. One is called polysaccharide vaccine, but that need regular boosting. The efficacy is not great. Of late, what we are getting conjugated vaccines. It is conjugated with the protein. The efficacy is much higher. The company insists 1 dose, but sometimes the risk is very high. We can take 2 doses. Who needs to take the vaccinations? Not everybody. People who are risk, people are food handlers, yes, they are supposed to take. People are keep on eating outside food, at least the intensity, severity can go down. So children, they're supposed to recommend. Right now, WHO is coming up, conjugate vaccine only 1 dose. They come up with a good guidelines in pediatric populations also. Adult populations, food handlers supposed to take. People eating outside food, they need to take. Not once and twice. If they're eating most of the time, take the food vaccine. So in short, how to approach your tropical fevers? When the person's presents with the fever, first thing we need to ask whether the patient is a stable patient or unstable patients. How to know whether a patient is stable or unstable? Use a Q-SOFA score. What is Q-SOFA? Altered mental status, respiratory rate, systolic BP. Altered mental state when the patient is not conscious, not giving the history, respiratory rate more than 22, systolic BP less than 100. The person out of 3 parameters, 2 parameters positive, stabilize the patient. Next thing, try to localize any diseases, for example, fever, dysuria, urgency, urinary tract infections, fever, cough, shortness of breath, pneumonia, fever, headache, altered mental status, meningitis. Try to localize. If there is no localizations, then it may be acute undifferentiated fever. In acute undifferentiated fever, look for the durations. If the fever is 3 to 5 days, mostly viral, maybe influenza, maybe dengue, maybe chikungunya, and the illness is crossing more than 5 to 7 days, either typhoid or leptospirosis or scrub typhus. Typhoid eating outside food, leptospirosis walking in the rainwater, scrub typhus exposed to the bushy area. I'll show how to differentiate further also. So this is a typhoid summary. Young people, gradual onset of fever. The fever may last 5 to 7 days. Bowel disturbances, either diarrhea or constipations, eating outside food most often. If you see the WBC count, the hemoglobin may be normal or slightly reduced. Total differential count in adult populations is mostly below normal or normal. Differential count, eosinopenia will be there. Platelet count may be normal or slight reduction is possible. If you see the LFT, SGOT, SGPT, more of SGPT compared to the OT. SGPT more elevated compared to SGOT, but it is not crossing 5 times, 10 times. What happened in viral hepatitis, we know. It can go into thousands, but in typhoid, it can go up to 200 to 300. If you see the bilirubin is essentially normal. And if you do the sensitivity pattern, all drugs is working. Cotrimoxazole, ampicillin, amoxicillin. You can use azithromycin, cefixime, but what is not working? Fluoroquinolone is not working. Keep in mind. But remember, you're in India. We can't say typhoid come alone also. If the person is eating outside food, bitten by a mosquito, walking in the rainwater, wading in the rainwater, it can come anything. So learn about the dengue. For example, dengue means sharp onset of fever, less than 5 days of fever, some amount of abdominal discomfort, maculopapular rash will be there. If you see the WBC count, hemoglobin is elevated. In the typhoid, the hemoglobin is normal, but total count is normal or below normal. Both typhoid and dengue, the total count is below normal. But here, the differential count, lymphocytes predominant, eosinophil may present, but there eosinopenia will be there. Here, platelet is too low. In typhoid, platelet is normal. Here, SGOT, SGPT, but more of SGOT compared to the SGPT because dengue is a systemic illness causing more of body pain. Bilirubin may be normal. So this is a case of dengue. If you want to see the leptospirosis, yes, the person should expose to the water, either rainwater or some agricultural work. You need to go to the agricultural field, paddy field, stands in the field. And second thing, or some swimming activities he's supposed to do, or some adventurous sports you need to do. And fever crosses more than 5 days, yes, not like dengue. And the person has got headache, back pain, body pain, retroorbital pain, cough pain will be there. But what is a test? Don't go with a MAT test or MSAT test. Look the hemoglobin. Hemoglobin may be normal or slightly reduced. WBC count is elevated. Dengue, typhoid, WBC count is below normal or normal. But here the WBC count is elevated, both in lepto and scrub. Scrub needs bushy area. We need to search for the SCAR. Platelet is low, but not like dengue. SGOT, SGPT, mild elevations, but more of alkaline phosphatase. That is called cholestatic pattern. Similarly, bilirubin may be elevated. That's a classic thing of it. So what about the influenza? Already discussed about it. The malaria. Malaria, the hemoglobin is bit low because hemolysis can happen. WBC count may be normal or below normal. More of indirect bilirubin. Platelet can drop. Again, monocytes will be more. Compared to the eosinopenia, monocytes will be there. So there is no entity called clinical malaria. According to national policy, there is no entity. Malaria should always prove probable typhoid, probable leptospirosis, probable scrub typhus, okay. But there is no probable malaria. We need to make a diagnosis of malaria by doing a smear or rapid test. Don't say this is my experience. Intermittent fever, chills and rigor. It is not valid. Government of India removed presumptive treatment of malaria is gone. That's gone. So don't use it. The influenza, no sick contact. It's more important. Running nose, cough, colds, sore throat. Already Dr. Neminathan talked about it. I don't want to touch about this one. So in summary, sharp onset of fever, 3 to 5 days of fever, more of body pain, rash, dengue. Malaria means fever, intermittent fever, chills and rigor, but we need malarial parasite test by either QBC or COD. Typhoid, young people, outside heating, eosinopenia, normal WBC, normal ESR, think about it. Leptospirosis, walking in the rainwater, wading in the rainwater, yeah, and the WBC count is elevated, cholestatic picture, think about it. So this is an investigation chart I usually do based upon the hemoglobin, based upon the WBC count, based upon the platelet, OTPT, and alkaline phosphatase. We can able to reasonably, this is not 100% sensitive, 100% specific, but good lab, it gives good idea what next we can do, that we can able to identify this one. If you want to know this type of tricks and tricks, you can scan this QR code and join this newsletter. We are producing newsletter every 15 days, updating whatever happening in the infectious diseases. Point, you can read through your WhatsApp. This is very simple. You not 5 to 10 pages of newsletter, journal article. We can compress this in 5 lines. What key points you need to learn, you can learn it. By sending SMS, you can join also there. I sincerely thank the IMA CGP for giving a wonderful opportunity. I provided sufficient time for interactions. Most of the time we end up without interacting the thing. We are ending at 7 o'clock and we are winding up. So today, even though I mentioned 7 o'clock, we are given sufficient time to interact with people. Thank you for the opportunity. I'm happy to take a lot of questions. Couple of questions already posted there. Thank you, sir. I stop sharing now. Mohan sir, I finished, sir. Thank you. I'll just take in. You can post your questions.
Yeah, so thank you very much, sir. Yes, there are like few questions they wanted to ask.
You want to put questions, people, please put. Almost 900 people still sticking there. Please put your questions.
Yeah, if you want any questions, just type the questions in the chat box so that we can have the discussion. Yeah, please. Hepatitis B vaccine for healthcare professionals.
Raghunath sir is there, otherwise I'll take it up.
You can take it up, sir. Yeah, I think.
Yeah, hepatitis B vaccination is a mandatory for all sorts of healthcare worker, whether the person is a housekeeping staff, whether it's a nurse, whether it's a doctor, everybody need. Couple of months back, hepatitis B vaccination shortage was there, but now shortage is gone. If you are not taken hepatitis B vaccinations as a child, most of the healthcare workers, 30, 40, they have not taken. They're supposed to take.
Thank you, Dr. Raghunandan sir. Thank you, Dr. Suresh, for the elaborate discussion on hepatitis and typhoid. Friends, if there are any questions, Mohan will coordinate.
Yes,
Mohan.
Yes, sir.
Yes, sir.
Myself, Dr. Suresh, and Raghunandan sir will answer the questions.
Okay.
Mohan.
Oh, yes, sir. We are answering, sir. Sensitivity of
Dr.
PCR
Mohan.
asking for the typhoid. Yes, sir. Mohan, sir.
I will put the. Sir, we can hear you. I'll just share the ID slides, sir. Just 1 minute.
Dr.
Course
Mohan,
slide,
you can
so
ask
that
the questions.
Yes.
So people are asking about
Sir,
PCR
till
for
the
the
slides, sir.
typhoid. Yeah, PCR for typhoid.
Go ahead,
asking
sir.
about it. The PCR for the typhoid is not a good modality because the sensitivity is not great. We tried the modality, but the typhoid PCR is not picking up well. The sensitivity is very poor. Again, the specificity also. Always PCR take pinch of salt. Not only for typhoid, any PCR, whether it's a TB PCR or a leptos PCR, any PCR, the PCR can find out the genetic material. It is not going to find out the living organism. Just pick up the genetic material. The genetic material may be the live, may be the dead. That's one. And second thing, the processing is very, very much clean. Otherwise, contamination can cause a lot of environmental bacteria gene can present with you. That's the other problem. So as far as typhoid PCR is concerned, it's not a great choice. You have to go for a culture or look for yeast opinion.
Thank you, sir.
How many days we can look for splenomegaly? I showed the graph week 1,
Yes.
week 2, week 3 presentations. In week 2, we have seen splenomegaly most of the time because first week people start developing fever and the spleen start enlarging. By the second week, you can able to appreciate the splenomegaly very well.
Okay.
Sir,
the one more question, like Septran. Do we have the Septran cotrimoxazole work in typhoid infection, especially during MDR typhoid?
Yes, we have shown the data there. Cotrimoxazole is a beautiful drug, not only for typhoid, it is a good drug for E. coli, it is a good drug for Klebsiella, it is a good drug for rare organisms like Nocardia and it is a good drug for MRSA2 also. So this is a good drug, but people think about self-allergy, always ask any allergic to the medicines or not, particularly self-allergy before writing the cotrimoxazole. Whenever you write cotrimoxazole, sidely on the sidewards what I do, there is no self-allergy, I'll ask the history and strike it off. That's more important for you.
Even in pediatrics, we see lots of children who are resistant to ciprofloxacin and other drugs sensitive to cotrimoxazole. So cotrimoxazole is coming back.
People are asking about why azithromycin for 7 days. Azithromycin, the basic difference between azithromycin and cefixime is azithromycin is an intracellular acting. It suppresses the protein synthesis. But the cefixime and ceftriaxone is a cell wall active agent. And you know salmonella is an intracellular organisms. So if you use a cell wall agent, it will take some time to clear. But if you use azithromycin, it acts rapidly clears the bacteria and clears the bacteria. That's why the durations of azithromycin is slightly less compared to the cefixime or ceftriaxone because these are all cell wall active agents. Cotrimoxazole, again, this is an intracellular acting agent, but the durations we want to usually keep 7-10 days is a minimum timeline we want to keep it there.
And the advantage of azithromycin is that it has got post-antibiotic effect. Even after the antibiotic has been stopped, it has got effect. So recrudescence of typhoid fever is very minimal in azithromycin. So, but the only thing is never use double drugs like cefixime, azithromycin, already emphasized by Dr. Suresh Kumar. You can use only one drug.
Antenatal mothers traveling to India, do they need to typhoid vaccination? Yes, typhoid is a killed vaccine only we are using, not giving oral vaccines. That is not available right now. Oral is a live attenuated, but it's not available. Usually we are giving the killed vaccines, polysaccharide protein conjugated vaccines only. Typhoid, TCV is a brand freely available right now. That is a killed vaccines. Usually when the person traveling to India, the risk is high. Usually most of the vaccines we give the second trimester. If really needed, yes, you can. How do they confirm
Is there any, if there are, Mohan, please post the slides about infectious disease also. Meanwhile, when they are asking question, you can post the slides. Doctors who are listening this conference, if you are interested in joining fellowship in infectious disease course, you can contact any one of us, either Dr. Suresh Kumar or Dr. Raghunandan, Dr. Mohan Kumar or myself. And Dr. Mohan Kumar is displaying his number on the screen. You can see the Dr. Mohan Kumar's number. You can call him. The course is already started. You can join the course immediately. You can continue with the class. So you can see the displayed number and then join this course, because we are all the core committee members of this infectious disease course. So I request all of you to note down Dr. Mohan Kumar's number, which is displayed on the screen, and then contact him. Yeah.
Questions I'm answering, sir. TCV booster doses. Usually the company insists and the data insists one dose is enough. This is a conjugated vaccines, not like a polysaccharide vaccines. Usually polysaccharide vaccines, we need to give booster because that's not effective. Conjugate vaccine doesn't require booster. But if the risk is very high, one more shot. One shot enough. If needed really one more shot, we can repeat. The data is not strong. Canteen employees need to take typhoid vaccination. Yes. Not only typhoid, we need to check the hepatitis A also. Dr. Nagarandan sir has talked about how the hepatitis A and E, hepatitis A vaccines and typhoid vaccination is mandatory for the patients. People are asking about the PDF to get the thing. Yes, the organizers will arrange for it. Incomplete treatment. When the person is not completing the entire course, the relapse rate will be high. Even if you complete full courses, the relapses can happen. If you are not completing the full course of treatment, for example, the cefixime or ceftriaxone, the total durations of 14 days, you are not completing, the relapse rate is almost 20 to 30% there.
And in typhoid vaccine in pediatric age group right from 6 months of age we are giving, and we recommend a single dose. We don't recommend a booster dose.
People are asking how to confirm the blood culture has only 40% sensitivity. Data is already there. Data is already existing. People did the study, but only thing how much blood we send, that's most important. If you want to get the positivity, send sufficient volume of the blood, and without antibiotic is ideal. But even if the person is taking antibiotic, try to send the blood cultures as soon as possible, as much as possible. That's most important thing there. If you send 2 sets, 40 ml of blood, the yield is much higher. I told about typhoid.IgM. It has got negative predictive value, good negative predictive value. Day 4, day 5, if you do a typhoid.IgM and the pretest possibility is low, if it is negative, you can stop typhoid medication. That's ideal, but it is not going to help salmonella paratyphi. Raghunandan sir, sir, people are asking about how many years later we need to take hepatitis B vaccinations.
Yes, sir.
Yes, sir, one question is that after completing the course of hepatitis B vaccines, for how many years once we need a booster up to age limit? What age limit?
5 years.
The age limit for long
I think, I mean, depends on your antibody titer. I think just now we verified that also. Anywhere above 10 is okay. 100 is ideal, but anything below 10, better you get even one dose of booster vaccines boost your antibody response. So I think those who are at risk, I think every doctor can check your, maybe Dr. Suresh, you can tell me how,
yes,
how often should we check?
Once you check the after completing the vaccinations, we usually check the titers, sir. If the titers is more than 10, that's what US recommendations. If the more than 10,
how often we should repeat? How often?
No, sir. Once we check the titers, when the titers is more than 10, there is no need to repeat the titers or repeat the vaccinations because it has got long-lasting memory. Even if the titers goes down in the future, the memory still start producing the antibody. So one titer more than 10.
So no need for booster.
Correct, sir. One titer of more than 10, you are protected lifelong.
Okay.
The message is, once your antibody titer is at one point of time in your life, it is more than 10, because of the presence of the memory cells. Whenever an antigen enters the body, typhoid antigen enters the body, body animalistically produces antibodies to take care of the illness. So the titer may be low, but body will produce antibodies adequately in a matter of seconds. So because of the presence of the memory cells, so you need not repeat the titers.
So people talking about typhoid in pregnancy, yes, all diseases, when the mother has got infected, chances of going to the fetus is high, particularly in the first trimester when the organ formation is happening, yes, possible. But usually the impact is not great like other viral infections. Typhoid is not that bad for the children there. ID course duration is asking Dr. Mohan, sir.
Yeah, it's this
ID
space,
course
sir. It is 6 months.
Mohan, please, Mohan.
Yeah. So I'll just quickly run through this slide for the information. Dear friends, we are doing this fellowship course in infectious diseases, and this is the 5th cohort. For the past 4 years, we have more than 300 doctors who have completed this course, and we mainly focus on enriching the general practitioners about handling infectious diseases. Okay, the main objective is to update your knowledge, create a platform for us to discuss like this, clear your doubts, and also try to enrich our practice the way we are handling the hospitals, prevent the hospital-acquired infections, prevent ourselves from getting infections, and also we are also opening a research forum. So it is basically online for 6 months, and every alternate Sunday, 10 a.m. to 1 p.m. 3 hours we do the courses, and we'll be having three speakers talking about syndrome of interest or the current prevailing topics. We also have 2 hands-on sessions, and we will be identifying a place where you can all join together and do the hands-on, one in lab and another in bedside. Not mandatory, but it is optional, but we encourage everybody to do. And we have examinations, that is in the form of assignments, written exam, and viva. This is primarily in person. And we handle clinical syndromes like acute febrile illness, pneumonia, diarrhea syndrome, jaundice syndromes. We also had special diseases like TB, HIV, lepto, malaria, dengue, fungal, and special population like infection in children, elderly, immunocompromised, pregnant women, non-communicable diseases. We also handle infection control like AMR, antibiotic stewardship, biomedical waste management, public health focus like surveillance, vaccination, occupational diseases, emerging infections, new pandemic diseases. And we use an integrated learning platform where we give access to the learners who have registered the course, give the PPTs, class recordings, do assignments, have discussions about cases, scenarios, and then go so on and so forth. And we have when we take a topic, we call this the expert of the topic, either national or international, to take the class. So we'll be having different speakers coming and talking about it. For example, for HIV, we had Dr. Kumarasamy sir from VHS who gave a talk about HIV/AIDS, and we have recorded the session too. So it's like that. And thanks to IMECGP and Tamil Nadu State Chapter and the Medical Council for it. And we also give credit hours 1 hour per the session. So it will be around 12 to 14 credit hours we will be getting. And this is a core team, and my number is displayed down. So if you want to be interested in joining, please let us know. I can guide you. Okay. And thank you all. And sir, for the want of time, yeah, anything you wanted to tell Dr. Raghunadan sir, Neminathan sir, and okay, I think Sir Suresh Kumar sir, any last points from your side?
I have answered a couple of questions already asked in the chat bot. So whatever questions, please be answered in person also. Don't worry about it. We have shared the thing, and we're going to share our PDF, already shared with the course organizers. So feel free to ask us for 11. We are happy to help you out in the future also there. So yes,
thank you, sir.
Thank you.
Thank you, sir. I think we are coming to the end of the day. Thank you all for the wonderful listening and the nice discussions. Over to IME, CGP, Tamil Nadu chapter, sir, Sendil sir. Okay, yeah. On behalf of IME-CGP, I thank you all for joining the day 1. As you all know, it is the first day of this CGP conference. Tomorrow at 4 p.m., we have another bunch of presentations there. So kindly join for the next 5 days. Remember, the last day is in person. If you are in and around Pollachi, please attend in the Pollachi IMA. And thank you all for the patient listening.
Yeah,
We
thank you,
have
sir.
Dr. Sindhu sir. Sir, over
Yes,
to you,
sir.
sir.
Thank you so much, sir. You have given vote of thanks as well. So this shows
Yeah.
how strong the team is. It's a very good teamwork, and it gives a very good impression to all our candidates. So first of all, I thank our speakers, star speakers of the day, Dr. Neminathan sir, Dr. Raghunandan sir, Dr. Mohan sir, Dr. Suresh sir, and all the audience for giving a very good presence. Almost it was like 1000K till the middle of the session, and even at the end of the session, just before the end, it was around 950, 900. So thank you so much, sir. And I request all our participants to join tomorrow at 4 p.m. sharp. We'll be starting our session. Tomorrow it's going to be a lifestyle diseases like mainly focusing on hypertension and diabetes. And the credit hours for the entire conference will be 6 hours. So kindly attend all the days throughout the session. And the session registration is open till July 12th, which falls on Saturday. As the many participants had difficulties in registration and also paying the paying the screenshots. So I request all the members to continue registering till the end of the conference. And thank you all for the overwhelming response. Thank you. Thank you all.
Thank you, sir.
Thank you, sir. Thank you for the platform.
Thank you, sir.
Thank you, everybody.